All right. Welcome, everyone. We are so excited about this forum today. My name is Thursky. I am the Director of the Royal Melbourne Hospital Guidance Group and also the Director of the National Centre of Antimicrobial Stewardship. And last Friday, we celebrated NCAS's 10-year anniversary. And for those of you who know our team, we do work in a One Health capacity. So we're very lucky to be able to work with aged care, our vets, primary care, and recognising that rural regional Australia, we know actually many of our GP friends actually work with their veterinary colleagues sometimes, sharing their experience with antimicrobials. So we knew that there was a gap that we needed to fill, and that is to support our rural regional colleagues across Australia to undertake learning and capacity building across both managers and clinicians, and see how we can help you today. So hopefully the program today is going to be really innovative. It was a little different way to have to do an acknowledgement of country today, because we have people from all over the country representing every state and territory joining us online. So welcome everyone online. You're very warmly welcomed. So in the spirit of reconciliation, we acknowledge the traditional custodians of the country throughout Australia and their connections to land, sea and community. And we pay our respect to their elders past and present, and extend that respect to all Aboriginal and Torres Strait Islanders peoples today. I heard a beautiful acknowledgement of country the other day, and he said to us, don't just talk about our land, talk about our world. And we do know that our Indigenous colleagues have an enormous wealth of knowledge and building capacity in a different way than we have through our very Western lens. Next slide. The next thing I wanted to do was to show you who's online. So I was so excited when I went through the list last night, having looked to see the sort of people who are joining today. Typically when we have an AMS forum, we have our gaggle of AMS pharmacists, of which we have I think we have the highest number of AMS pharmacists per capita in the world, just quietly, because when I visit my European colleagues, I was very fortunate to do my sabbatical in Italy this year, and they had no AMS pharmacists in the university hospital that I was involved in. So we have an amazing skill set here in Australia. But you can see that we have all sorts of people from leadership roles, both medical, nursing, infection prevention, as well as quality and safety managers. Really excited and welcome our aged care colleagues here today, because as you know, the aged care sector has recently funded on-site pharmacy program, which I think has been only taken up in a relatively small percentage, 12% of homes. But AMS is going to rapidly grow, hopefully, in the AMS sector. And some of us have been busily writing grants that we may find out about in a couple of months' time. And then, of course, even technical people here. So, and a national education lead. So I don't know who that is. I can't remember, but very, very welcome to you. And we do have representation from every state and territory, and public and private. So we do have to remember in antimicrobial prescribing in Australia, 80% is in animals, 20% in humans, and in total, most of our prescribing actually occurs in the community rather than the hospital. And a lot of our evidence that we use to talk about AMS actually comes from hospital evidence rather than evidence coming elsewhere. And of course, it's heavily skewed with pharmacists and medical. So we're really looking forward to hearing particularly the impact of some of our programs where it's nurse-led, particularly in rural regional Australia. So hopefully by the end of today, you'll get a feeling for, and we want to hear from you as well, the barriers and facilitators, what makes it difficult, what are the things that can help you to implement. And when in my capacity building in the sepsis space, I really enjoyed working with rural and regional hospitals. I always felt that the bureaucracy, layers of bureaucracy were much smaller. You get things done easier. How do we best measure our impact? And the reason why that's important is that all of us are under-resourced to do it. And therefore we need to understand how we can advocate for ourselves as a group to our own managers, to government, to make sure that this effort is funded. And if you think about in terms of international models, I think Japan is the only country where there's actually reimbursement for AMS activities. In Australia, there is no reimbursement model for quality activities particularly, and it's always an issue for us to try and get resources to do this work. And so I'm hoping that when we have our panel section later, and welcome to Felicity Loxton from Safer Care Victoria, we've got Christian McGrath somewhere, maybe not here yet, who's the Deputy Chief Health Officer who will also be on the panel, and Zaal, who will also be joining me for that panel to understand how we can set the priorities for government in particular. Slide. This is the program today. First of all, we'll hear about some of our colleagues' successes and programs around models of care. We'll then have a break. How long is the break? Is it 20 minutes? 30 minutes for the online people. We'll let you know. And then we're going to come back. You're going to really enjoy this because Professor Lisa Hall, who's in the back, is an amazing facilitator for workshops, and I've seen her in action. She's really impressive. It's going to be both the online people and the room will participate in that workshop, and then we'll come back at the end for a panel. And during the day, please, write down questions. If you don't get a chance to ask them, we're very happy to respond to you and follow up formally. You might have ideas that you want to speak to one of your colleagues. We can help that networking. Next slide. We talk a lot in our team, and this is literally how we design, how NCAS designs all its programs. We explicitly recognise the importance of the local, what we call the learning health framework. The learning health framework, you will see used more and more. We see it used in government, in policy documents, in the new NHMRC strategy. The learning health framework explicitly recognises the need for data, using data, and I'm not just talking about qualitative as well as quantitative data, to create knowledge, and with that knowledge, allow us to effectively design pathways or models of care, technology, and other interventions that are going to impact quality of care. Then we need to make sure that they're appropriately designed and implemented. In our team, we are now explicitly involving user interface experts, implementation science, human factors experts. And these are some of the people that we involve in our grants and our programs. Many of these you don't have access to, I suspect, in rural regional Australia, but there are lots of opportunities for us to connect you with people like that, to get a second opinion or help you design a program. And I cannot sort of undersell the joy it is working with someone who understands the science of implementation and the science of co-designing a well, and it'll save not only effort, but your return on investment will be much greater. Next slide. This is a slide showing appropriateness from the NAPS data across all the different hospital categories. This is public hospitals. It looks a little bit different in private. And I'm just showing you, you can tell that the principal referral hospitals sort of started off even in the early days in NAPS with relatively high rates of appropriateness, narrow confidence intervals. And as you come down into those smaller rural regional hospitals of very wide confidence intervals, some significantly reduced appropriateness, this is directly related to resourcing, access to experts, and everything else that comes with being in a rural regional setting. And this really has been a very important tool for us to understand where we need to invest our efforts. And Kaz Chen, who's online, I think one of our PhD fellows, has recently analysed the data over 10 years and has shown in that data for hospitals that have regularly participated in the NAPS, there's been significant improvement in appropriateness of up to 23%. So measuring and auditing and feeding back your antimicrobial quality of use will improve appropriateness and lead to improved patient outcome. You'll see this a little bit later this afternoon, but understanding how to advocate and what you need to do to create business cases and arguments for support is a particular skill set that I bet some of you didn't have. I certainly didn't have it. You know, the skill of writing a business case is and making the case for a business case is a unique skill set. And something that we can all learn, and we can also, certainly we have some templates and support within NCAS to help you, but this is the framework that Lisa's going to be using for the workshop this afternoon. And so I'm going to finish off now. Our chairs for today, and I'm really so pleased to welcome, have a chat to them when you can as well. So both Jenna and Zohal are antimicrobial stewardship pharmacists who work with me in the guidance team. They are extraordinarily experienced. Zohal came to us from the Alfred Hospital. Jenna has been at the Royal Melbourne Hospital. These are pharmacists who have deep understanding of implementation challenges.
In this first session, we're going to be hearing from 3 great examples of how our regional teams are delivering AMS in practical ways. Each of our speakers today are going to share their unique perspective and showcase how AMS services can be adapted across different regional settings. So our first speaker today is Dr. Tom Schulz. He's an infectious diseases and general physician based at the Royal Melbourne Hospital. For more than 10 years, he has been providing infectious diseases support to Goulburn Valley Health in Shepparton. He has a strong interest in delivering care at a distance to ensure that high-quality healthcare is available to people wherever they live in Victoria. Welcome, Tom.
Thanks, Jenna, and thanks for the opportunity to speak today. So I'm going to speak about AMS, well, beyond the tertiary hospital, really what we're talking about here today. Yeah, next one, thanks. And really the development of an AMS support and rounds in Shepparton. Thanks. So Shepparton is about 180 kilometres northeast of Melbourne. It's about 70,000 people in the greater Shepparton area, about 35,000 people in the town. It's a really ethnically diverse group. Something like 17% of people don't speak English at home. There's a lot of migration from overseas. And that applies also to the health staff. The health staff in the hospital are very representative of the population in the town. As a bit of background, something like nearly 10 million people live in regional Australia, so that's about 1/3 of the Australian population. Overall, it's less well-resourced if you look at number of specialists per person, number of GPs per person, and lots of other services per person. It's an older population, nearly 7 years older median age population in regional Victoria compared to Melbourne. And there's poorer health outcomes, both in terms of health behaviours, smoking, alcohol, obesity, and outcomes, ischemic heart disease, cancer, and other things. So we have less resources and a sicker population. Some years ago, I was involved in some focus groups with Jacqueline Bishop, who did a PhD around regional antimicrobial stewardship. And I think this statement's always sort of stuck with me. I think from a regional infection control nurse, I think the thing I worry about is that I think our patients are getting second-rate care. And I don't think any of us want to think that patients anywhere are getting second-rate care. So not in response to that, but preceding that, I started going to Shepparton in about 2010, doing outpatient clinics, and then became aware that the hospital had a need for infectious diseases support. And through Royal Melbourne, we developed an infectious diseases support program for Royal Melbourne. And it included, for Shepparton. It included 4 components: clinical support, education, infection control, and antimicrobial stewardship. I'll talk a little bit to each of them, but then focus on antimicrobial stewardship. So clinical support really involves quite a lot of phone calls each week, and that's largely junior doctors, but also infection control nurses, senior staff, and so forth, to the infectious diseases physician on call, and then the registrar after hours. There's things that they're obliged to call about, so that's staph bacteremia, endocarditis, prosthetic joint infections, tuberculosis. And the one we really encourage people to call about is, if you're not sure, speak to ID. That's sort of the goal of what we're providing. Education, we do talks to junior and senior doctors as part of ongoing medical education, but probably some of the most important education is the ad hoc little bits that you give with each of those phone calls, a little bit about what do you do with the catheter-associated urine infection, what do you do with a staph bacteremia, and so forth. We're involved in infection control meetings and particularly development of policies. And I think one thing that larger hospitals can provide to smaller hospitals is not reinventing the wheel in terms of the development of policies, both infection control, AMS and so forth. They can be very time consuming to develop. And if you can provide a 90% policy that just needs someone to review it and say, well, look, check that this is site applicable, that really can save a lot of time and effort. And then antimicrobial stewardship. So the first bit of the antimicrobial stewardship program is that Goulburn Valley doctors get approvals for restricted antimicrobials via a system called Cold Fusion, which is a software developed by their own hospital. And that needs to happen. So you can give a first dose of a restricted antimicrobial, but any subsequent doses need to have an approval. And that sort of triggers off the approval process subsequently. Those approvals are then reviewed by pharmacy, and then we do a twice weekly virtual AMS round. As part of AMS, we're also involved in an AMS committee. There's policy development, as I was mentioning. And then I think Kaz mentioned the importance of feeding back data and results to team to develop to change behaviour. So how does the AMS round work? So the AMS pharmacist prepares the round and presents the patient. So they look at what antimicrobials they're on, how long they've been on, what the indication for them is, how long they are planned to be on, and so forth. It's done through a Teams meeting. I sit in Melbourne and the pharmacist sits in Shepparton. ICU also joins and presents their patients on a weekly basis. We have both access to both radiology and microbiology, so we can look at things and discuss what the appropriateness is. I then make a recommendation in using guidance software. That then populates into the Cold Fusion software to their handover document for the junior doctors. Now, unfortunately, they still have a paper-based system, so there's also a process of writing the recommendation into the notes, which is, when the paper-based note is the sort of source of truth in a hospital, unfortunately, that becomes a part of the process. Next. So yeah, probably one of the tricky bits is getting the software to talk. And I think those involved in guidance who spent that time doing that would recognise that you can have fabulous standalone systems of software, but unless they can communicate between each other, that is really the difference and the difficulty that can be a barrier to getting things done. But once it does work, it really does provide us a great way to directly input into the notes and have our advice recognised, I think, because the problem, as we know, with phone advice is it's subject to what gets written down and what gets translated and so forth. Again, back to that survey that we did, this quote I like. You just need a good pharmacist as an expert for them to call when they need help. And I do think that whether it's a good pharmacist or a good infection control nurse or a good clinical practice nurse, you know, that source of an expert to really sort of answer the questions when it gets a bit tricky is what a lot of people are looking for. So what's worked for us at Goulburn Valley? Initially, we had keen young pharmacists. They were fabulous, but they all left after about a year because they got opportunities and went elsewhere. Shad, our pharmacist now, I don't want to say he's not young and fabulous, but he is fabulous. He's not young, but he's a senior pharmacist who's been involved in the hospital for a long term. He's very experienced, overseas trained, and has a lot of gravitas within the hospital because of that experience. And we've also encouraged now all pharmacists to do AMS. So all the pharmacists rotate through the presentation of the AMS rounds, which has taken it from a one-person based model to a more sustainable model. Things that really help in terms of the program. So accreditation definitely helps. I mean, that stick that says you need to have an antimicrobial stewardship program within your hospital really acts as a driver for implementing the programming and continuing it. Crises are also useful. Before the program started, the hospital had a problem with staph bacteremia, a bad clinical outcome, the lawyers involved and payouts. And all of that really made them very aware that poor management has costs and consequences. Data is very important, and I'll talk about that. But I think also personal relationships are very important, and anything that involves sort of outside people stepping into a regional hospital needs to be done at a long-term model, needs to be done not as a we talk down to you, but as a let's communicate and see what both of our needs are way of communicating. So data can be really useful. This is the NORSE, which is the National Antimicrobial Use Survey Program. I think that's what it stands for. but where antimicrobial use gets funneled into and then compared to like hospitals. It's a little bit small, but what you can see is the thick line is Goulburn Valley and the dashed line is like hospitals. And the azithromycin prescribing at Goulburn Valley is much higher than other like hospitals, and the doxycycline prescribing is much lower. And you can use that data to feed back to ED and others and say, look, your practice of giving lots of people ceftriaxone and azithromycin for severe pneumonia is out of keeping with other hospitals, and that has the potential to modify behaviour by being able to clearly show in data that it's not just you rabbiting on, but it's actually evidence-based. Similarly, other areas like hand hygiene. Just this week, I did grand rounds as part of antimicrobial stewardship for Goulburn Valley. We were able to say, well, the hand hygiene rate at Goulburn Valley is a bit below what we're expecting. It should be 85% is the sort of Victorian recommendation. 2 wards in particular, which happened to be the medical wards, had the lowest rates of hand hygiene, and one group of practitioners in particular had low rates of hand hygiene. And again, being able to show the data, directly feed it back, can take you from being a sort of nagging external force to, well, you know, here's the data. The nurses are in the same ward as you with the same resources, and they seem to be able to manage to wash their hands. Other data is useful, and I think Kaz has spoken to how NAPS data can be used to alter practice. You get an annual comparison of, you know, how often do we document the indication? And I think the first time we had this, our level was at about 25% or something. And so over a number of years, we've managed to improve that with that ongoing comparison to national data. And now we haven't seen that nice upslope in appropriateness of antimicrobial use, Kaz, which I guess is an ongoing challenge for a hospital. But again, being able to really feed the data in and say, well, this is where we stand has been useful. Because conversely, the surgeons have really, they're the standouts at Goulburn Valley for whatever reason. They just, well, I don't know what the secret is, but I do know that a good lead is a key part. If you've got someone who says, well, you know, they're the ID physicians, they know what to do, let's listen to them. That is a big, and the other thing is really the anaesthetists do most of the antimicrobial prescribing for the surgeons. So if you get them on board, they are a big driver to successful surgical prescribing. So what have been barriers? I think staff turnover is a big barrier in regional hospitals, and that happens at all levels, from CEOs to chief medical officers to junior doctors. The overall staff level of experience is less and very varied. So many staff have come from hospitals overseas where the problem of antimicrobial resistance is very different to here. And then to not sort of translate the everybody needs meropenem from where I was working to here can be a challenge. Limited IT resources. I mean, at Royal Melbourne, we have Epic, which is a fabulous system. At SHEP, we're still working with paper-based records. And ongoing financial commitment is important, because if you have things on just 1 and 2 year budget cycles, that puts a lot of time put into business cases and so forth. So if you can get that ongoing financial commitment, that is a barrier to overcome. Sustainability, expanding funding to allow an extra EFT has been very useful. So now it's not just me, there's another ID physician, and we have a roster of support. And also having all the pharmacists doing AMS has again allowed sustainability. Much if myself or Shad, the lead pharmacist, stepped out, it would leave a hole in the program. I don't think the program would fall over like it would have some years ago. And just one achievement to take us back to that crisis that got things going, staph bacteremia being poorly managed. We took part in the SNAP trial, which is an international trial of staph bacteremia management. We had patients randomised, and I think the hospital can be quite proud to say that of 150 sites worldwide, Goulburn Valley was one site in an international trial that was probably going to change practice in terms, or will change practice in terms of management of staph bacteremia. So it achieved multiple goals. Obviously, it's good for overall knowledge, but I think being involved in a trial heightened the awareness of the appropriate management of staph bacteremia within the hospital. So in summary, your postcode shouldn't determine your access to healthcare. We need to move away from individually centred models. Lack of local ID expertise should not stop antimicrobial stewardship, but I think you do need a source of expert advice is needed who is accessible, accountable, and I would argue approachable. Thank you. any questions.
Thanks for your talk, really interesting. A question about the clinical support service that you offer. I mean, you mentioned that there's you and there's now a second ID position. Thank you. And you have a roster. Does that extend to after hours, or does Royal Melbourne and your colleagues there step in to cover the after hours service for Golden Valley?
Yeah, so in hours, it's the ID physicians, myself and Max, who are the other ID physician. After hours, it goes through the Royal Melbourne ID registrar. There has been some agreement that some money will transfer to Royal Melbourne for that, because especially with changes in EBAs and so forth, it's more expensive to call it registrars after hours, but it's the ID registrars after hours.
Yeah, okay. That's helpful. Thank you.
I'm just so struck by that surgical prescribing, because I don't know if you're aware, but if you look at SNAP's data nationally across all craft groups, inappropriateness is around 50%. So like you're way outliers. Are the surgeons involved in your stewardship program formally?
The anaesthetists have been, so the head of anaesthetics has been involved on the AMS committee, and she's she's an excellent woman who provides excellent care, and is, again, that person who's been there for a while is respected within the hospital and by the surgeons. And when they say, this is what we're going to do, there has been a strong, well, if that's what we will do, you know, we're not that sort of, I'm a surgeon, therefore I'm an expert in everything, but I'm a surgeon and I'm happy to get expertise in other areas.
We have one question online.
So Michael Loftus has his hand raised, so I'll ask you and Michael can ask your question.
Thank you. And thanks to Michael Loftus here from Alfred and also Mildura.
If I can turn the volume up. Sorry, Michael.
No worries.
Is that?
How's that? Can you
That's
hear me in
enough,
the
yeah,
room?
go for it.
Sorry.
Hi, so Michael Loftus here from Alfred Hospital and Mildura. I guess we've stumbled across a model through COVID where we, in our AMS 2-hour window, will dial in the junior doctors, sometimes registrars, sometimes consultants, and have a 3-way conversation between ID physician, AMS pharmacist, and a member of the medical team. I guess was curious your thought. I mean, we only do that once per week, so not quite as regular as yourself, and that may prove to be too much of a barrier for the junior doctors. But just your thoughts about the potential of that model to get that direct communication. It's hard to get the tech to talk to each other, but if you've had any experience with dialing in the medical teams to present the cases rather than that burden going onto the pharmacists. I'm conscious often that things aren't written in the notes and you can't read their minds.
Oh, yeah, sorry.
No, correct. I mean, that's the model with intensive care, so they do it. I guess Golden Valley's sort of that size hospital where there's about 3 medical teams and there's a rehab team and there's a number of surgical teams that you would need about 6 different teams dialing in, so that wasn't really feasible. Royal Melbourne also provides support to Hamilton, which is a smaller hospital, and they do use that model of a 3-way where either the medical registrar or the surgical registrar presents the cases. But just with the multiple teams, we haven't made it work.
Thank you. We've got a similar model down at Zaal. We liaise with some ID physicians that work at Alfred. We find it does take a lot of time still out of the pharmacist's workload. Do you know how much time it takes the local pharmacist to, do that twice a week?
It's each round takes them the best part of a day. So their funding for AMS is, I think, about 0.6 EFT. Correct me if that may be wrong. But they usually do the morning, and then, by the time they then put the note, unfortunately have to go back and write stuff back into the physical notes. It does take quite some time.
Okay, good. It's not just me then. That's great.
Oh, it's a comment actually. So years ago when we put together what was it called? Antimicrobial Stewardship in Australian Hospitals, which you can still get online with the Commission. It's been updated. There's 45,000 chapters now. It wasn't before. But we actually put up the EFT required per bed size. So we used to have 1 EFT per 250 bed pharmacist. And I actually noticed that that's the level that's been supported for aged care, 1 EFT per 250 beds. So I think we need to come back to making, as you say, the resources required as substantial to effectively do stewardship.
I absolutely agree, Kaz. I think a key to a proper program is resources, and that is staff resources, primarily pharmacy, but then also that ID physician. If you're trying to get an ID physician advice and, you know, paying them $3,000 a year or something, or if you're trying to get a pharmacist to provide a comprehensive program and giving them 0.1 EFT, it's not going to work. And it's particularly from that sustainability perspective, it's not going to be sustainable.
All right, we might have to leave it there. Thank you so much, Tom. Round of applause for you again. Next up, we have Sarah. Sarah is an infectious diseases physician at the Royal Brisbane and Women's Hospital and the director of the Queensland Statewide AMS program. She has a strong interest in antimicrobial stewardship and innovative ways of delivering infectious diseases and AMS support to diverse patient populations. Welcome, Sarah.
All right. Can everybody hear me?
Yep.
Oh, okay, great. Well, thank you so much to the organising team for the opportunity to present today. So I'm presenting on behalf of our team at the Queensland Statewide AMS program. We'll give both an overview of our program's activities as well as the role of nursing staff in the delivery of regional, I guess, AMS as well within, you know, our experiences in Queensland. So the Queensland Statewide AMS program was implemented in January 2017. We provide tailored AMS advice and support for rural and regional hospitals and health services in Queensland who don't have local ID physicians or medical microbiologists. Our program's focus is on understanding the rural and remote context and the creation of a tailored AMS program for these health facilities that best meets their needs. We have a strong focus on education and training, incorporating all disciplines of medicine, nursing and pharmacy, which reflects our own multidisciplinary team and the different team members and different roles that we all play in the rural and remote context. Slide, please. So QSAMP supports 4 main hospitals and health services in Queensland, each of which has their own unique needs and differences in how AMS is managed. These services are Torres and Cape, Northwest, Central West and Southwest hospitals and health services. Within each of these hospitals and health services, there are multiple facilities that we provide support to, which includes larger hospitals at each of our sites, as well as primary healthcare clinics and residential aged care facilities. So staffing at these sites does vary from rural generalists to GPs and clinics, as well as obviously at some of the smaller sites and primary healthcare clinics, which may be nurse-led facilities. Oh, sorry. Before. Yeah, perfect. So QSAMPS provides obviously support to very geographically different areas within Queensland. And within HHS, there are different structures and procedures in terms of their local AMS programs. And as such, there's really different levels of support that are needed within these different health centres. Most of the health facilities don't provide any dedicated funding for AMS activities, and as such, multidisciplinary staff then incorporate AMS activities into their daily roles. All of these things have really added to the complexity and the need for QSAMPs to develop really locally applicable and meaningful AMS services which can be integrated within each HHS. So key to QSAMP's engagement and success at sites has really been the development of local relationships and both assessing and listening to local AMS needs to gain an understanding of the differences and challenges that they encounter in the rural and remote space. Over the last 2 to 3 years in particular, we've really focused on working with local stakeholders to develop innovative ways to integrate AMS activities within existing workflows with an emphasis on education and training of staff to develop sustainable AMS programs. We've really focused on local engagement with stakeholders at each site such that we're seen to value add within each facility. So within the program, we provide comprehensive AMS support. So this incorporates clinical advice, which is available through our hotline, both for ID physician and AMS pharmacist support, therapeutic drug monitoring, education and training, as well as antimicrobial surveillance and auditing support, and local quality improvement project support. So our AMS ward rounds occur weekly for each HHS that we support with multidisciplinary team attendance, and we consistently have excellent nursing and pharmacy attendance at all of the sites that we support. Cases at rounds are presented by local team members with in-depth case discussions and a focus on education and building knowledge. Additional local education AMS needs are also identified during our ward rounds, as well as from analysis of our consult database that we keep as well. Resources which are applicable to the rural and remote space are also available freely on our website, which is accessible through the Queensland Health intranet and available to all Queensland Health staff. Education and training, as I've touched on, are really important components of what QSAMPS does. And really our aim is to develop sustainable local AMS programs and build knowledge. So our medical and pharmacy education programs include monthly formal education statewide online sessions. We also have education which is embedded into ward rounds and local education presentations on requested topics, which can include, for example, during our site visits. Nurses are a really critical part of the AMS multidisciplinary team, and at some of the sites that we support, as mentioned, they may well be the sole practitioners. Our nursing education program aims to promote nursing understanding and involvement in AMS activities. In recent years, there's been increasing recognition of the importance of the nursing role in AMS. However, their roles still remain underutilised in hospital AMS programs. Within the rural and remote context, nursing staff have been recognised as the discipline with the lowest turnover and highest stability, which is certainly what we've observed within our program as well. Collaboration between all team members is really critical for the successful implementation of an AMS program, and acknowledging this, since 2018, the Australian Commission of Safety and Quality in Healthcare has provided guidance on the key AMS practices for nurses and midwives. So they detail 7 areas in particular when nurses and midwives support and influence AMS, many of which these staff members actually undertake on a daily basis and may not recognise these contributions to AMS. Specific aspects of AMS that would benefit from formalising the nursing and midwifery involvement include empowering staff to initiate discussions of antimicrobial indication and duration of therapy, as well as supporting them to promote, for example, the switch from IV to oral antibiotics. Within our program, we are incredibly fortunate to have dedicated funding for an AMS clinical nurse consultant, Bridget Brodie, who plays a key role with engagement of nursing staff and HHSs that our program supports, focusing on understanding and promoting their role in AMS and helping to develop critical thinking skills through a comprehensive education program and support. Bridget really continues to build on the strength of the education program, which was established by Stephen Notcher, who's since retired. There's some of the challenges, certainly that we've encountered in the rural and remote context, which are, I guess, not uncommon and this audience is well aware of, are things like staffing and high staff turnover, as well as staffing capacity and competing responsibilities and priorities with the potential for loss of engagement of staff. From a nursing perspective, AMS is often not well taught or potentially not taught at all in some of the undergraduate nursing and midwifery courses, and as such it may well be poorly understood. And additional challenges within the nursing field include a perceived lack of inclusion in AMS decision making and AMS education programs, the lack of AMS nursing role models, and competing local learning and training requirements. In terms of addressing these challenges, over the last few years, our nursing staff AMS program is really focused on the enablers of nurse engagement in AMS. So we actively encourage nursing attendance at our AMS ward rounds, and these are routinely attended by IPC staff as well as nursing staff at remote facilities and provide opportunity for case discussions and education. Our site visits have been really important in terms of developing relationships with local nursing and midwifery staff. And in addition to education sessions and forums, we also encourage participation in local quality improvement activities, which includes surveillance. So as mentioned, our site visits have really been essential to developing local relationships. We visit each of our sites once a year And for each of these visits, we have representatives from the medical, nursing and pharmacy members of our team, with the focus being to connect with our local partners and stakeholders, assist with their on-site education and training, as well as meetings to discuss their local AMS needs and gain an understanding of their local context, as well as the differences and challenges that they encounter in their particular setting. And these visits really have provided incredibly valuable insights into the local capabilities and the challenges that they face. So one of the successes that we've had within our program over the last few years has really been a structured nursing and midwifery education program. This was initially trialled at a single HHS in 2020, and then it's evolved to the program that we run today. And this includes monthly online education sessions. We've also got embedded within nursing orientation packages, set presentations from QSAMPs, and we're involved in all of those, as well as ad hoc case study presentations, which are requested, for example, if there's a case of sepsis or so forth at a local site that they wish to go into further depth with, we'll support with that. And we'll also present at their local HHS online education programs as well. Our monthly education program is really focused on core AMS topics, which were identified in consultation with our local key nursing stakeholders, looking at opportunities for improvement and really where we could get bang for buck and provide locally applicable and meaningful education that nursing staff could incorporate into their daily practice. With regards to our monthly education program, to promote our monthly education sessions, we send out advertising information and a calendar invite a week before, and that goes out to all of our key nursing stakeholders, as well as all of the nurses and midwives on our distribution lists. All of our education sessions are recorded and they're all accessible through our website. And so if people can't attend at the time when the session is on, they can always go back later and watch it at a later time. We also record and analyse nursing attendance at our sessions. And in addition, we also request anonymous nursing feedback through a QR code and Microsoft Forms survey. So this feedback and attendance records really allow us to continue to develop locally relevant education sessions to encourage ongoing engagement with our program as well. Some of the challenges that we've had in terms of implementation of this education program have included both identifying as well as maintaining relationships with key local education stakeholders, also acknowledging some of the staff turnover in these sites. Within the nursing education program, we really want to meet local needs and build sustainability and resilience, and as such, identifying some of the local AMS issues and learning needs to allow us to focus on those have been really important. Local nursing educator and leadership support has also just been wonderful in terms of providing support on the ground, which has included encouragement for nursing staff to attend, as well as helping us identify the best day and time that suits most facilities to encourage attendance. Local quality improvement activities that QSAMPS has engaged with nurses and midwives on include involvement in NAPS surveys. So at a number of our sites, we've actually upskilled midwives in terms of undertaking SNAPs, as well as upskilling of infection prevention teams to undertake hospital, surgical and aged care NAPs as well. We've also assisted in terms of locally identified areas of need and developing education packages as well. Slide, please. Great. We've also collaborated with local staff members on, as mentioned before, some of the locally identified AMS issues and concerns, such as routine urine specimens and antibiotic prescribing for asymptomatic bacteriuria in residential aged care facilities, which has led to a change in practice and cessation of routine urine testing. To encourage the best practice in terms of collecting pathology specimens, such as urine specimens, wound swabs and blood cultures. We've also collaborated with local staff to develop education posters as well. And moving on from these things, for 2026, one of the things that Bridget started work on already is really looking at developing further education on blood culture collection practices within our facilities as well. So this is my last slide, and say thank you again for having us here today. I think really key to QSAMPs and what we've been able to achieve within the program and meeting local needs has really, I guess, been meeting with the local staff on site, getting an assessment of their local AMS needs, and then developing workflows around that such that we can really assist them and then integrate into their local practices. I must also acknowledge the amazing work that Bridget Brodie has done over the last 12 years. She's just been amazing in the role and continues to go from strength to strength. And obviously also Stephen Notcher, who was integral in terms of setting up the education program. And I think this presentation is really a celebration of their work.
Thank you so much, Sarah. That is all really, really impressive. It sounds like you've got a really great education program set up, and yeah, we'll have to take some notes. Does anyone have any questions for Sarah? Yeah.
Are your online education sessions available outside Queensland or only for Queensland employees?
Just within Queensland Health at the moment. We've had some requests certainly from health centres outside of Queensland. And so based on individual request, we've on occasion provided, obviously those education series to them, but it's not a routine thing that we do, no.
Thank you.
So impressive to see all that presented. Congratulations. I'm going to ask the Dorothy Dixer in the room though, because it's great when you see all this, but what are your challenges and what are you battling on a day-to-day basis?
I think some of the challenges and battles on a day-to-day basis are things that we've touched on already in terms of like the lack of dedicated AMS funding within sites and the fact that people are so busy and have so many other responsibilities within their roles, and it's a constant juggle in terms of then incorporating AMS on top of everything else. And so to see dedicated AMS funding within facilities would just be amazing.
With targeting or delivering the education to nursing staff particularly, I think that's a really interesting thing that we don't talk about enough. But when you are delivering nursing education to a lot of remote and rural sites, how many on the frontline nurses are you getting, or is there value in just connecting with the infection prevention nurses at the sites? Because those people tend to have a little bit more time to attend a meeting, whereas we all know trying to get any kind of nursing education done, you're given 5-minute slots at the beginning of handover, or it can be really challenging.
Yeah, I think there's different components to that. So in terms of our formal education session, obviously attendance can vary depending on local responsibilities and what else is going on. Libby, our pharmacist, actually, who's here today, actually did an education session on Wednesday this week with Bridget, and he had, trying to remember how many people attended that session. 45 people attended that session, which is, just wonderful to see in terms of that. With regards to our ward rounds, what we find is it's primarily the infection prevention nurses that we see. And even on the slide I've got up, there's John and Darcy are both infection prevention nurses who are attending from sites. I think as well, just on that, it's one of the reasons why we're really happy and prepared to adapt to what local sites need. So for example, at one of our sites, there's a Fruitful Friday nursing education session. We're really happy to present within those sessions and also, have education at other times as well. And I think we've got the opportunity, because we've got funding for an AMS CNC within our program, to really develop to that and say, what do you guys need? We can do this for you. That's totally fine, not an issue. We're here to help and we're here to work out what works best for you as well. So we can very much adapt.
the approach that I've taken off, and I mean, I believe nurses are the coordinators of care, and so the more we can upskill them and empower them to do stewardship, the better we're going to be. But one real opportunity is to make sure that you're part of your sepsis program. Sepsis gets a lot more, I guess, you know, there's an explicit clinical care standard now for sepsis, which was developed in together with after the clinical care standard for stewardship, but we were on this, we were part of building that out, and it's a really good idea for all of you to think about how to make sure that you're implicitly or explicitly involved with your sepsis pathway. The reason I'm saying that is I have developed up an APRA accredited nursing role. She's at Peter Mac Belinda Lambros, but I think it's a transferable skill set. And Belinda is APRA accredited to do stewardship, skin prick testing, delabeling, neutropenic fever, she runs outpatient clinics, and she supports a sepsis program from audit, feedback, education, and then has research wrapping around that. But that role, I mean, yes, it's in a cancer setting. I think it's a transferable curriculum. So if anyone wants information about that, just contacted me after.
I think we have one question.
Oh, yeah, sure.
I
think
guess
there's
it's
another
kind of
question.
for everyone as well, but Bianca Mills has asked, has anyone fed back to undergrad providers that AMS should be integrated into the RN degrees? Has anyone engaged or reached out to the nursing colleges? Yeah, Lisa?
As the token university educator in the room, it is incredibly challenging to get anything added to either nursing, pharmacy, medicine, any of the accredited programs. They are so tightly locked down. It's tough. So we continue to advocate. I'm just thinking how long it took to get hand hygiene added, which like is a little bit mind-boggling to start with. But yeah, so there have been efforts made in the past. We continue to try and do that. The amount of hours, even within a medical program for teaching infectious diseases with integrated programs, is shrinking. So if they're not even getting basic micro, let alone infectious diseases until they're out in their clinical years, how are we getting the stewardship? So I don't think it's just a nursing thing. I think it's all the clinical professions. And I think we'll just need to be a little bit savvier about how we package these things up. And I think the best way to go about it is actually working with, not necessarily with the colleges, but the people actually doing the teaching. Because if you already have a time slot, you can sneak some stuff in. That's what I do. Anyway.
Thanks, Lisa. And then Arjun just made a comment online just so that everyone in the room is aware of the conversation too. But he was just saying the principles of AMS have been included in nursing education, but more targeted content could be promoted, especially as part of their clinical placements. Yeah.
Thank you, everyone. Thank you again, Sarah. That was lovely. Okay, our last speaker today is Emily Hayes. Emily is a hospital pharmacist with New South Wales Health, currently practicing at Shoalhaven Memorial Hospital on the south coast of New South Wales. In her current role as an AMS pharmacist, Emily provides support across 3 hospitals within the Illawarra Shoalhaven Local Health District. Having grown up and worked in regional areas, Emily's interests lie in advancing stewardship practices in rural and regional settings, with a focus on collaboration, education, and the utilisation of clinical decision support tools to enhance antimicrobial governance and prescribing quality. Welcome, Emily.
Yeah, that is a weird. I like that.
Yeah.
Thank you.
And then just sending in.
Thank you. Thank you for having me, everyone. As mentioned, I'm Emily, and I'll be talking about the collaborative methods and tools that we use to deliver an AMS program in the Illawarra Shoalhaven Local Health District. So the Illawarra Shoalhaven Local Health District, as you can see on the map of New South Wales, it's represented in pink just below the metropolitan Sydney area. On the enlarged image of Islip, or the Illawarra Shoalhaven Local Health District, you can see it contains 8 public hospitals, ranging from Coaldale up the top to Milton Ulladulla down the bottom. This is an area of about 6,000 square kilometres, and it delivers health service to about 400,000 people. So for context, Wollongong Hospital, this is the largest hospital in this region. It's a major referral and teaching hospital, and that's located about 1 hour south of Sydney. If you travel an hour further south, you'd reach a town called Nowra, which is where Shoalhaven Hospital is located and where I'm primarily based. Shoalhaven Hospital, it delivers a pharmaceutical service to 2 other hospitals. So David Berry Hospital, which is about 20 kilometres north of Nowra, and then also Milton Ulladulla Hospital, which is about 60 kilometres south of Nowra. Okay, looking a little bit further into the regional AMS landscape, on the top photo here, we've got Shoalhaven Hospital, which is where I work. This is a hospital, it's got about 200 beds. It's a secondary acute hospital, and it's designated as an MM3 hospital. So MM refers to the modified Monash model, which describes metropolitan, regional, rural and remote areas. So MM3 is described as being in a large rural town of about 15,000 to 50,000 residents. Looking down the list of photos, there is David Berry Hospital, which is in the middle, that has a palliative care unit and a rehabilitation unit. There are about 25 beds at David Berry Hospital. And then the last photo there is Milton Ulladulla Hospital, which is a rural acute facility. There are about 30 beds there, and both David Berry and Milton Ulladulla are referred to as an MM5 hospital, which is described as being in a rural small town. So there is one AMS pharmacist, which is myself at this stage, who I work in this role 2 days a week at Shoalhaven Hospital. We do have limited on-site ID coverage. So most of our specialist support is Wollongong based. There is no ID physicians at Milton Ulladulla or David Berry hospitals. We do have an ID physician at Shoalhaven Hospital, although all of our AMS activities are coordinated through Wollongong AMS physicians. So it's very much a networked model across Islip. Okay. Now I'll look at some of the collaborative methods that we utilise to deliver an AMS program. Shoalhaven Hospital, we do function independently with regards to delivering an AMS service. However, collaboration is a big part of our service to ensure the patients aren't disadvantaged by a lack of resources. Firstly, we do virtual AMS ward rounds, which occur twice weekly. This is with the AMS pharmacist, myself at Shoalhaven Hospital, and ID physicians in Wollongong. We utilise guidance to facilitate this process. So I can import all active antimicrobial prescriptions into guidance. I can filter them by highly restricted antimicrobials and add them to our ward round list, which is shared with the physicians. And I'll review these patients who might be in need of an AMS review. So for example, patients who have expired approvals, or complex patients, or with tricky indications as well. So they'll get reviewed and interventions will be documented within guidance itself and also on the patient's electronic medication record, and I'll follow up with the appropriate teams to get these actioned. The next one we have here is our AMS committee meetings. This is also delivered on Microsoft Teams, and it's a district-wide multidisciplinary group between the AMS pharmacists and ID physicians to oversee the AMS program. So this includes AMS pharmacists at Shoalhaven Hospital, Wollongong Hospital and Shellharbour Hospital. They occur every 2 months, and here we review or maintain local guidelines, policies, coordinate education campaigns. And we'll also look at our NORSP data, so the National Antimicrobial Utilisation Surveillance Program data, which is great for identifying prescribing trends or unexpected changes in our prescribing patterns. Moving on to the weekly AMS strategic meetings. This occurs between the AMS pharmacists between Shoalhaven Hospital, Wollongong Hospital and Shell Harbour Hospital, and ID physicians in Wollongong. And this is more of a local discussion about our AMS projects, initiatives and problems. For example, we've recently been talking about how we'll proceed with the World Antimicrobial Resistance Awareness Week and how we will engage with staff and deliver education. Finally, on this slide, we've got the Prescriber AMS hotline, which is another collaborative model utilised at Shoalhaven Hospital for instant advice on antimicrobials. So it's a phone service that connects to an ID or AMS physician in Wollongong Hospital, and that can be utilised for general advice, guidance approval extensions, or the prescribing of highly restricted antimicrobials. And it can also be used to find information from the microbiology lab at Wollongong Hospital. The final way in which I'll talk about how we collaborate through AMS is the Clinical Application Advisory Group meetings, or our CAG meetings, which are monthly meetings which offer cross-district collaboration between the Illawarra Shoalhaven Local Health District, South Eastern Sydney Local Health District, and also Sydney Children's Hospital. So the focus here is on governance, which might include review of guidelines or implementations of policies or procedures, drug committee submissions, and the optimisation of AMS applications and digital tools. So here I've included some examples of how CAG has improved patient safety. So the first one on the list is the gentamicin and now tobramycin dose advisor, which was built to help improve safety regarding aminoglycoside dosing. So this is incorporated into Cerner, which is our electronic medication record system, at the point of prescribing to provide real-time decision support. The initiative was reviewed and it was shown to reduce gentamicin prescribing errors. It was also recognised by the CEC Antimicrobial Stewardship Expert Advisory Group, and it led to statewide implementation. Down the list, we've got CAG, which has been heavily involved with the guidance content review, and particularly this year due to the updates to the therapeutic guidelines antibiotic update. And a lot of time has been discussed in building pathways for the clinical decision support algorithm, which is largely based on the therapeutic guidelines, but also our own local antibiotic resistance data. And the update to the guidance content has also led to discussion about how we would classify and restrict our antimicrobials. So for example, intravenous tobramycin has now been de-escalated from highly restricted to unrestricted. The next is the IV to oral switch project, which was the implementation of an EMR alert, which flags IV antimicrobial prescriptions that are likely suitable for safe conversion to oral therapy when a patient meets established criteria. Once this is flagged, the patient will have an AMS review. This can be done with an ID physician, and if appropriate, an intervention will be placed for IV to oral switch. Other examples would be building in stop dates to certain low-risk antimicrobials to avoid inappropriate extended durations, and also the creation of power forms in EMR. So this has been done to improve ease and accuracy of prescribing for drugs used in desensitization and also sepsis drugs. So as we can see, this partnership between sites, it broadens our perspective and allows regional hospitals like ours to influence local adaptation of statewide tools, which is specific to the needs of our regional population. As mentioned, guidance is our main decision support platform, and it's used daily for antimicrobial approvals. They're developed by the Royal Hospital Melbourne. It has therapeutic guideline access, which can provide real-time prescriber support. A benefit of guidance is that it can facilitate ID oversight remotely, and it thereby supports the continuity of AMS service across multiple sites. In a regional hospital such as Shoalhaven Hospital, guidance acts as both a communication and a clinical tool. So it has strengthened the pharmacist's role as we can review approvals, indications, identify trends, and provide feedback to prescribers. It's particularly useful in my area as we have a high turnover of staff, which I think seems to be a common theme among regional places, or often junior pharmacists or people that might be new to the hospital setting. For this cohort, pharmacists can rely on the decision support algorithm, look for the approval number, look for the indication, and that can help guide our clinical review process, which is useful if we're just starting to expand our knowledge in this field. Whilst pharmacists can greatly benefit from guidance, prescribers, including our junior doctors, can gain confidence to make evidence-based decisions, even when ID isn't physically on site. So here I've got some screenshots of how the decision support tool would be used for people who might not know from a doctor's perspective. So the guidance is used to, can be used for either drug-based or indication-based prescribing. So for example, we were to select amoxicillin and clavulanate as our drug, select our indication, we tick the box that says use decision support algorithm. We might be asked additional questions like, is the patient in sepsis or septic shock, or is there penicillin hypersensitivity? And we will be given some resources and recommendations. So the resources link to the therapeutic guidelines, which can be opened in a new window. And our recommendations, we have the first line or preferred options at the top and the second line or alternative recommendations towards the bottom. The drugs can be selected and approval for the antibiotic or antimicrobial can be granted. Here I've included a study which demonstrates the how we've used demonstrates how collaboration and how the use of guidance has improved our AMS service. So this study is titled Outcomes of Multi-Site Antimicrobial Stewardship Program Implementation with a Shared Clinical Decision Support System. So my health district, which is the Shoalhaven Local Health District, was one of the participating sites in this study, which evaluated the implementation of guidance as a Shared Clinical Decision Support System, or CDSS. And this was across several New South Wales hospitals. The study demonstrated that collaboration between hospitals using a common CDSS can lead to significant improvements in antimicrobial usage through enhanced adherence to guidelines. So this was shown through a reduction in use of broad-spectrum antimicrobials, a reduction in cost of antimicrobials, and also reduced rates of healthcare-associated C. diff infection. So this has highlighted the importance of strong communication between sites. And for ISLID, having a shared platform and collective knowledge base has allowed for greater alignment of stewardship practices across geographically dispersed locations, while also enabling coordinated interventions with less workload at individual sites. Now, I'll just briefly talk about some of our successes and challenges. So successes would be strong inter-hospital collaboration and shared stewardship culture. So there's also improved access to ID input and education via virtual rounds and the AMS hotline. Finally, guidance has promoted standardised evidence-based prescribing from the use of the study that I just mentioned earlier, which is evidenced by the study I mentioned earlier. But unfortunately, nothing comes without its challenges, and some of these might include maintaining engagement across our smaller facilities with fewer prescribers and encouraging new doctors who are new to a regional area to utilise guidance and the decision support algorithm. However, this can be managed by having guidance training and orientation sessions. The next point would be limited local AMS resources. Back on the previous slide. Such as part-time AMS staffing and no on-site ID AMS physician. Although we do compensate well with our virtual ward rounds or alternative methods in which we collaborate. And finally, Shoalhaven Hospital has experienced a period of limited pharmacy staffing, and this is quite significant. So this could impact my time as an AMS pharmacist also when we're pulled in different directions. So it does make it tricky sometimes. I'll just finish up now with our key takeaways. So firstly, vital care, Virtual care is now a vital and everyday part of how we deliver care and the AMS service across our regional New South Wales. Collaboration and connectivity are the pillars of an effective AMS service within ISLID. Virtual ID support and decision support tools like guidance are enablers of safe, consistent prescribing, even when AMS and pharmacy resourcing are limited or not available every day of the week. And finally, one of the biggest lessons regarding stewardship in a regional context is that it's much more about enabling clinicians to make safe, informed choices through connection and support than it is about just enforcing restrictions. And that photo that I've included there, that's the Shoalhaven Hospital redevelopment. So it's a new hospital at the same site, but it's going to be much bigger. So hopefully that brings forth some new opportunities in the future. That's it. Thank you very much.
Thank you so much, Emily. That's a great example of how, yeah, you can use other hospitals within your local health network to really help support these more smaller regional hospitals as well. Are there any quick questions from the audience? I think we have one online.
Yes.
Yep.
What's your medical staffing like for MM5 facilities? One of the things we've worked with locally is getting GP PMOs, for example, who, you know, run a practice or you know, are sort of half in the hospital. It's hard enough to get them to write in the notes, let alone use a decision support tool for their antimicrobial prescribing. Like, how do you get through those challenges?
Yeah, very much is still a challenge. So in David Berry Hospital, we essentially have one doctor there who's there Monday to Friday. Milton Ulladulla has changed recently. I used to work there and we had, it's GP run as well. So there was a junior doctor and also all the GP admitting medical officers as well in the morning, and then they all used to go to their GP practice and wasn't really, many people there in the afternoon. Although that has changed and there is now a junior doctor there all day, but it can still be challenging, encouraging engagement for those sites at those facilities. There is a pharmacist who's at Milton Hospital Monday to Friday, so they can be utilised to provide education regarding the use of guidance. It's a bit different at David Berry Hospital. There's a pharmacist there one day a week. So being a rehab unit and a palliative care unit, it's quite a sort of slower turnover of patients. So yeah, that's definitely more of a challenge. Yeah.
So in the Victorian context, we've got each hospital is run by its own board. So in the Gippsland region where I'm from, we have 11 different hospitals with 11 different boards, which each, if they would like to have an arrangement with a ID physician and reach out, if they each want to have a EMR, they need to set them up themselves. So that all needs to be driven from the bottom up. So I guess I'm interested to know from your perspective, where New South Wales, it does seem to be a bit more from the top down, and your role might be an example of that, where I work at essentially a similar sized hospital, but for me to reach out to the hospital down the road and say, hey, we can provide services, we have to ask them to pay for it. You know, it doesn't quite. How do you find that you have any pushback in terms of you sort of reaching out, or does that electronic system that you kind of have consistent across everywhere, does that really sort of help how you work? Or
our electronic system is consistent across ISLID. We don't have access to SESLID. A lot of, are you talking about like interacting with, say, our smaller sites that we look after?
So for example, like if you're collaborating with a Wollongong hospital ID physician, are they able to access the notes from Milton Hospital?
Yes, yeah, they can, yeah.
So we would need a nurse to take photos of the paper chart and send them to the ID physician. So it's a really, and I think all the hospitals have the same requirements to implement an AMS program, but you can imagine the resources. These hospitals don't even have pharmacists at them. So it's interesting to sort of, and it's really optimistic to see how that works really nicely
Yeah.
once it can get set up.
Yeah, so it's good. When I'm doing my virtual AMS rounds, our AMS physicians are going to be in Wollongong, but I might be talking about patients in Milton Hospital or Narra Hospital, and that can all be accessed by the electronic medication record system within these sites. It doesn't really extend beyond to Islip, though.
Yes, that's within the network.
Yeah.
There's 2 questions online, but we're definitely running.
Okay, it's great. It's here. Victoria has had 86 hospitals, 76. That's right. So we're sort of optimistic that with the new redesign of Australian hospitals into networks, that's going to reduce some of the barriers for that direct collaboration across the networks. Yet to see how it's implemented. We're in the Parkville precinct, so again we have 4 hospitals within a kilometre of each other, all with different boards and different systems, even though they've got the same EMR. So it's really difficult, but I think it's actually really important for stewardship, because I think at the end of the day, this is a systems approach to healthcare. We lift up and over, and we need to be able to work collaboratively with our partners across networks. It's just a base requirement.
Thanks, Cass. Sorry, because we need to have a break before the workshop, but just quickly, there was a question from Kerry Ann for you, Emily. When you talk about virtual care, are you using electronic records for medication charts? In our service, we still use paper-based charts. So I think you sort of answered that.
Yeah, so we do have an electronic medication record within ISLID, and so that's what we utilise, yeah.
And then Michelle Bibi asked, and this is probably more, Jenna, if you want to answer this one, is guidance suitable for nurse-led AMS programs and nurse practitioner prescribing?
Yeah, absolutely. We do have, so the way guidance is set up, prescribers all have access to the clinical decision support, and that includes already nurse prescribers. And all the content is completely flexible, so you can adapt it to, be more about, diagnosis and things like that, rather than, choosing the correct drug. So it's very adaptable and definitely can be used with both nursing, pharmacy and medical staff all across the board.
There is one more for Emily. And then I put in the chat, no more. From Bianca for you, Emily. Have you had any pushback or exceptionalism where local clinicians don't appreciate the virtual advice and prefer to go their own way as you aren't on site?
Sometimes, if that happens, or say there's no approval, or it's going against something that's been discussed in our AMS ward rounds, we encourage everyone to just please call the AMS prescriber hotline, and so it can be more of a discussion about where to go from there, or what are the reasons that we might have missed the first time. So yeah, utilise that hotline and see if we can work it out.
Thank you. All right, so
Lisa is an award-winning public health educator and research mentor, so we're very lucky to have her here today. Alongside Lisa, we have Dr. Zaal Meher-Homji. Zaal is an infectious diseases physician at Latrobe Regional Health and also Western Gippsland Health. He's also an adjunct senior lecturer at Monash University. Zaal completed his ID training at Austin Health and Alfred Health before he moved to the Gippsland region in 2021, and we'll hear about his pivotal role in building the AMS service there. So for today's session, we're going to hear a little bit about the journey at Latrobe, where they started, where they are currently, and where they want to go. And then Professor Lisa Hall is going to guide us through a interactive workshop that you're all going to contribute to. Thank you, Lisa. One more mic.
Just get a mic for Zaal, because I'm about to ask Zaal some questions. And then everyone's going to help Zaal on his advocacy journey. So thank you, Zaal, for joining us. Yeah.
I'm looking forward to having about a 200-fold increase in my EFT over the next 1 hour. So hopefully we can get some work done.
So we thought we'd start just by setting the scene. Do you want to tell me a little bit about your health service, Zaal?
Yeah, so I work at Latrobe Regional Health in Eastern Victoria. So a Gippsland region, we have about 300,000 people spread out over the geographic size of about Switzerland. Our major regional referral centre is LRH, Latrobe Regional Health, and there are also, we're one of 11 health services in the Gippsland region. So as Michelle was alluding to before, that is 11 boards, 11 executives, 11 protocols of all different shapes and sizes. But LRH is the sort of referral centre for the region. We have an ICU, we have specialty medical services, oncology, cardiology, specialty surgical units like orthopedics. We're a big orthopedic unit. And essentially where we're at the moment is we've just had a larger facility built on our site, and our bed numbers are expanding, our population's expanding as well. So and we've been seeing that in terms of our AMS and our antimicrobial use is going up and up each and every year.
Yeah. So you've got a range of complex challenges there. Everyone starting to think about the scenario. So I'm really keen to hear about how your AMS team has grown over time and who's in your team now.
Yeah, so I joined in 2021. I just had to get out of Melbourne in 2020.
Don't blame you.
But essentially, when I started things at LRH, it was all just service provision. Our pharmacy department was very understaffed, and so there was really no ongoing there was an AMS subcommittee that was meeting, but there was no ongoing sort of regular AMS activity. So the first year or two was basically me and my HMO rounding on patients once a week, or going around and meeting the teams once a week and doing a proper formal handshake round. So we've always done ours face to face. I know a lot of people are doing it virtually now, but that's always been something we've been doing and quite proud of, that we still sort of keep that face to face, boots on the ground sort of style. In 2023, we had Jackie Richards join our team. So she's an AMS pharmacist. She came across from Zaal and has been with our team. And I think that was really pivotal for us, going to sort of amateur AMS to sort of professional AMS, where we're actually, using our EMR, having, an EMR that actually helps us run the round. We have data. We're doing our naps more regularly. We're able to run education sessions. So that really was amazing. And then last year we had a very interested infection control nurse consultant, Rose Lane, join our team. So now she comes on all our rounds as well. So on our rounds we have myself or Alex Ty, my colleague, so we have 2 ID physicians at our hospital. We have Jackie, our AMS pharmacist. We have Rose, our IPC nurse, and we generally have a couple of junior doctors or nursing students as well. So we've been proud of the team we can assemble, and we're kind of really now just hoping to sort of take the next step into a more data-driven pre-approval AMS system.
So we're going to talk about the future in a minute, but I'm just thinking back about that growth. So going from what is almost colloquial called amateur AMS, which I think is the reality for a lot of locations regionally, right? You're doing what you can with very little resourcing, to having a great team really trying to push the boundaries. That already is great growth in a few years, to be honest, especially considering the funding climate that we're facing. What do you think was the most important factor or person that helped you grow that? Or did it just kind of come from a determination within the team, Zaal?
Yeah, I think there's probably a few things. So, I mean, the team itself is, I think, overall quite passionate and motivated. None of us do just AMS or ID as our role. We all have different sort of areas that we're working in the hospital. But we're all particularly passionate about AMS and sort of providing that as a service. We have a sort of a structure at the hospital where we have a monthly business meeting, and I think that's been useful where we have, we have ID, we have AMS, we have pharmacy, we have IPC, and then the general managers that sort of supervise those areas. And so that business meeting's been quite useful in terms of escalating our needs, resources to executive. I mean, we love to hate EMR, but our EMR has helped us, do our job, and it helps with generating data. It helps generate the list. Look, I think that data has been, again, really helpful for us to advocate for change, both, to individual units. We had the same issue with ED and azithromycin. We probably still do, but, being able to show that and bring about change has really helped.
So my last question before we launch into our activity, and this is a pivotal one, so everyone start to carefully listen now. I'll put my glasses back on, Zaal, so I can read it. Where do you want your team to be in 5 years' time?
So look, I think we need adequate cover for all our positions. So currently, as it stands, one person is sick or one person is away, and especially if that's Jackie, a lot of the time it's a real struggle to get an additional AMS pharmacist, an additional pharmacist to cover her role. So I'm really glad to hear that, other services, it's a whole pharmacy-wide approach to AMS, which is great. That's something we could certainly think of. So I think workforce is, keeping the sustainability of our workforce is probably the number one thing. We've reached out to the guidance team about trying to get a guidance approach for our whole region, so across our health services in Gippsland. And I think, the post-prescription review is great, but I think we're always sort of a little bit behind the ball game when it comes to antimicrobial use. If you're already, 2 or 3 days into a course of PIP-TAS that was inappropriately started. So yeah, I think that pre-prescription review and the decision support, integrating it with our sepsis guidelines would be amazing. I'd like to increase our sort of footprint in terms of our frequency of our rounding, particularly in high use areas like ICU. And yeah, definitely increase our regional outreach to the sub-regional sites in our region. So I think one thing we're thinking of with guidance is really making it a health service partnership model that
don't give them all the solutions. But I think you raise a really good point. This approach from moving from one hospital, one team trying to do it all, thinking longer term, what's best for sustainability. I think, and the elements you'd need. So you've talked about spreading your reach, focusing more on pre rather than post review. That workforce sustainability piece is huge. The data to back all of that up. Anything else on Centre's wish list?
Yeah, I think research as well.
Yeah.
We've been so snowed under with just service provision that, getting the chance to participate in research and be involved, in, I think we've got a lot to add as a regional centre in, collaborating with, projects internationally that,
Yeah, well, we've heard a couple of examples already this afternoon, haven't we, about how just being one of those 45 sites, you know, just raises the profile and awareness of what you're doing. So you've given us lots of thoughts. Thanks, Zaal.
Thank you.
I'm going to step out, introduce the activity now, and then Zaal will be coming back shortly after we've had a chance to all talk about it. But I want to talk about, I'm going to stand up now because I feel a little bit odd teaching sitting down. I just want to, we'll just make sure we're sharing this with people online.
Sorry, 1 second.
Just catching up. All right, just get the slides. Now I've put this photo here and people are like, why have we got a pop culture reference here? Well, I'm really feeling like it's a bit of Back to the Future at the moment, because I did recall when I was putting this together, hang on a minute, didn't I do this sometime in the past? And I remember running a workshop 2014, 2015, before we had the Queensland statewide program, around how were we going to uplift regional AMS in Queensland. And at the time we'd done a survey, and the results and the conclusion here at the bottom was deficiencies reported as barriers to establishing AMS included pharmacy resources, financial support from hospital management, and training and education in antimicrobial use. So yes, we've come a really long way, but I did kind of feel like we are still back where we were in some ways in the regional setting. And I think we've had a great example of some real leading stars doing things differently, but we've still got some challenges in a lot of sites. The other thing that drew me to this picture is he's wearing Martin McFly there is wearing a puffer jacket, which seems to be a very Melbourne uniform. So, and Rod, who works with us, just loves orange, so he's not here today, but we'll let him know that the orange puffer jacket is the new guidance uniform. We'll let him know that. Okay, next slide, thanks. So how are we going to build a case? Or as I like to say, how to win friends and influence your executive. Well, I'm going to go through a bit of an activity now. Next slide, thanks, Zohal. I'm going to introduce you to this advocacy framework that was put together by people working in Western Australia who do really amazing public health advocacy work that's relevant to the Australian context. And yes, public health advocacy is a little bit different because often they're looking at big scale, whole policy kind of changes. But this framework is really useful. It comes up as part of a toolkit that is freely available. We'll be sending in the link out afterwards so people can actually follow step by step through. We're not going to go through the whole thing today, but we're just going to go through the first few steps just to give you a bit of an idea about how taking a really structured approach to your advocacy can help you build a stronger business case and not just be the squeaky wheel. Because I do feel like sometimes in infection control and AMS, we're seen to, when things go well, no one wants to, deal with us. When we have problems, we're a problem. When we want more resources, we're the squeaky wheel. And yeah, you don't always want to be that way. You want to be the leading lights, actually having a business case that is solid. All right, next slide, thanks. So Advocacy 101, or this framework, has 8 key questions. We're going to go through the first few, but you'll see they're actually quite logical. But when you start to unpack these, if you don't do these in the sequence and quite carefully, if you try and jump all over the place, you do end up in a bit of a hole. So if you just start to develop your strategy, but you don't actually know what you're asking for, that's a problem. If you write your business case, but you don't know who it goes to and who can support it and who makes the decision, that's a problem. If you put together all the costings, but you don't have a way of working out how you evaluate it or how you even justify what you need, that's a problem. So all of these things, as I said, are common sense, but I love the idea, and we do this in public health quite often, just coming up with a set of ways and work your way through from the top to the bottom to build your case. And it's a circle, and it uses colour very similar to NCAS, so that drew me to this one as well. There's a number of them out there, but as I said, this one's freely available and it's been developed for the Australian context. It's got some really nice examples around how big changes in tobacco legislation, child safety have been driven by using this kind of framework. So if we can do that in this country, I'm sure we can do this with your local AMS team, to be honest. Okay, next. So your task today, we're going to crowdsource some advice for Zaal here. He's given us his wish list for the next 5 years. We want to work through what his team needs to realise the 5-year vision. So everyone here in the room, and we're going to be popped into some breakout rooms soon, has been given a template, and you've got the 3 questions on it. And we've also got some extra prompts that if it's really quiet in the rooms or on the tables, that we will chip in and try and get people going. But I didn't want to give you all the answers. I want to, as I said, see what creative thoughts. We've got a wealth of knowledge here in the room, and you've also heard some amazing examples already of things that Zaal might be able to actually leverage in his health service. So first question, what's actually the advocacy ask? Second question, what's the evidence? Now, I want to remind you, and I think a couple of people have mentioned this already, both data and stories are important here, right? Data appeals to some people in decision-making positions, but they see a lot of data, and sometimes it's the story that gets you over the line. Now, when I say story, that could be, isn't it accreditation story? Accreditation's coming up and you're really not going to meet it, and you got a not met last time, it was a real drama. What's your issue? What is your story? Is it a patient advocacy story, right? Has there been a bad adverse event and, you know, your hospital's been on the front line or your health service has been on the front line of something really awful happening, and it's been in the newspaper, and you want to leverage that. So think about, I'm not saying that, Zaal, you've had that scenario, but, you know, what kind of stories do you think that Zaal might be able to leverage in his team? And then think about who is Zaal trying to influence. But also, one thing we haven't really talked about are the roadblocks. It's the opposition as well, right? So if every time you're trying to put something in, there'll be someone else who doesn't want that, right? Quite happy the way things are, thank you very much. Whether it's, well, we've heard great things about surgeons this afternoon, but sometimes the surgeons can be the roadblock, for example, right? Who might be the opposition that Zaal's facing? So we've got 15 to 20 minutes, then we're going to report back, share some ideas, and have a bit of a discussion and see what we can pull together. So now we've got, for the people online, we've got, and I think the same rules apply here. Be respectful. Make sure you take good notes. Make sure someone is prepared to speak when we come back, because that's always a bit awkward if we have to voluntold people. None of this part is going to be recorded. So yeah, you can be really open and frank about the challenges that you face, that you think Zaal might be facing, but really think about those 3 questions, because this is going to help us build a case. And yeah, you've got 200 extra FTE in your brainstorming session this afternoon, Zaal. How good is that? All right.
Thank you.
So we'll see you back here for some discussion in 15, 20 minutes. We're unmuted, so that's all good. Okay, folks, let's get the show on the road, because it's been, I don't know about you guys, but it's already been a very long week. And I sense a general sense of, oh my God, so many problems, but so many good ideas. We need to have a quick chat and then move into our panel discussion to wrap things up. So, Zaal, do you want to come up and give people the thumbs up, thumbs down, whether you like their ideas or not? Maybe, maybe not. Now, just as a reminder, we had 3 questions. We may not get around all the tables. What we might do is we'll start with a table here, maybe a table online, see what other new ideas are coming. Then people from the room or online can add extra ideas. No one loves in a feedback session where someone reads out exactly the same as the previous 4 tables. So we'll try and be a little bit like smart adult learners here and not do that. But have I got my questions caught on the screen?
Oh, yeah, sorry. I was just fixing the camera.
I'm moving too much.
Yes.
Okay, here are our questions. All right. Who wants to, which table would like to go first? Anyone burning to go first? Thoughts, ideas?
My table in the back had some brilliant ideas.
Okay. All right. Over to you in the back.
Right. So I guess first part was, what were the advocacy asks to achieve the 5-year vision? We tried to pick up on some of your priorities. One of the first we came to was sustainable staffing. So, I think you've done a really great job of building a team that functions, but we talked already about what happens if one person leaves, one person goes on, and it's difficult to do on the run succession planning. So we talked about bringing in some of your existing resources, reaching out to some of the smaller, other facilities that are in your area and, seeing if perhaps the pharmacists or the nurses in those facilities can join your rounds and start to gain expertise, more sort of starting in a more passive way. And maybe even they'll display an interest because, part of it is not just we need the money for these jobs, but we need people to apply for them when they come up.
Too true.
Yeah. And so be giving an opportunity for that kind of, and looking at other things like ID advanced trainees to kind of, build that workforce as well, perhaps, through a more training lens as opposed to increasing your ID physician staffing. And I think we came up with is that, you're looking for a network solution, collaborating with those facilities, making sure that you're not kind of introducing any kind of guidance system as from a, big facility reaching out, but starting to build those relationships now and sort of, create those advice pathways. So it becomes a, relationship you already have that you're building on by offering that approval system rather than kind of saying, well, now you have to come through me if you want to use the drugs you've been using forever.
So to summarize that, a sustainable collaborative approach that builds capacity but doesn't majorly impact on cost.
To start with.
To start with, until you grow.
Yeah.
You like it? What do you think, Zaal?
That's fantastic. Jackie, you're taking notes? We're actually getting an advanced trainee next year, so we're very excited about that. And I think overall there's a lot of interest with junior doctors and prescribers when we do come around, and it's really trying to get through to the more senior staff, I find. So I think I need to work a little bit harder in getting our senior medical staff, our medical surgical registrars.
Answering question 3 now, Zaal.
Yeah.
Yeah,
Sorry.
but important to note. What did you have for evidence to support your business case?
Yeah, so I think a lot of it depends on, I guess, the nature of the facilities that you have in your surrounding network as well. Whether they've got the capacity to generate their own NORSP data or whether they're doing NAPS audits regularly and bringing that into kind of, because ultimately what you're hoping to propose is a networked solution. You want to be able to establish the scale of the problem on a, networked basis rather than relying, I guess, on the people who have the existing resources to generate the big picture data. Things like your hack data, we identified even if the facilities are not large, they'll have to generate that data and you can rely on that, again, to paint a more area picture of the kinds of challenges you're facing. And if you don't have that capacity to offer maybe to do NAPS data in those facilities, reach people out, send out the, your pharmacist or the
baseline.
Yeah, exactly. And use that as a way of building capacity generating data by doing these kind of audits. And then if you get stuck, pharmacy dispensing data is another good way of talking about, the drug is going out, they've got to be a measure and being able to use that. Looking at, through the accreditation lens first, these facilities all will have to do their own accreditation. So looking through this from a stories perspective, looking through, not METs they might have had or, who's their current standard 3 lead and how have they felt when they're talking to AMS in their facility? What have they been asked from their accreditation? And then, patient stories, events, critical events, complaints that might have come through, or even from your, consult service, ways that, you've been able to reach into those facilities and help out with individual patients, maybe keep them where they are rather than have them transferred, which obviously has a lot of traction with executive.
Yeah, they love that.
Yeah, and I think focusing on the smaller regional services in our area is something we haven't done, and maybe we need to look at more because they're the ones who are really, they don't have any support.
So they'll have the stories, Zaal. You just need to help them get the data. But I love the idea of looking at your other sources of administrative data that together with the customized kind of NAPS might actually help, set the scene. All right, who's Zaal going to influence?
Well, we've got a list of people, including surgeons, but we did say anaesthetics because obviously anaesthetics does the prescribing, right?
Yeah.
Craft groups are a big part of that, and I think we focused a lot on, you know, when you are asking, when you're doing your asking, obviously who are the people who I guess you need to make that case to that are going to need to action it. You know, we talked about obviously your local executive, but also the executive of those facilities, the health service managers, the educators in those facilities, the nurse leaders, because I think particularly in those facilities, they've got a lot of sway, a huge amount of sway, sometimes more than the doctors, who can sometimes be quite transient, and the health service managers obviously have been there sometimes for decades. At the larger end at Latrobe, your clinical safety stakeholders, your sort of accreditation manager, because they'll love, or your standard 3 lead, if you can talk about how you can, you know, perhaps build it up to the lead up to accreditation and those kinds of things, you know, put it through that lens, I think it's really, we all think it's really helpful. Obviously, then you've got your director of medical services, but also your directors of nursing and your director of pharmacy. You know, if you're struggling with the pharmacy resourcing, your director of pharmacy is going to be able to give you a good oversight as to what they're struggling with. Maybe they can't fill their existing pharmacy positions, and having coming to them talking about getting more is going to be, it's not going to be received as
So
well.
kind of put your story alongside and your ask alongside someone else's, kill two birds with one stone kind of angle, maybe.
Yeah, if you can. I think it's what we find really hard, like, is that, you know, you're obviously competing in a really strained environment everywhere, you know, anything.
Everyone's got their own business case, right?
Yeah, and getting away from
Hunger Games.
Yeah, exactly. And it is really hard because, you know, you might hear about something that the pharmacy department's really struggling with. You might be like, actually, that is a priority. Actually, and I am going to do what I can to support you in that thing, so that maybe when, you know, that's
When that comes around, that person can also help. I'm going to stop this table now. Fantastic ideas. We're going to go to a table online. Who have we got?
There. Yep, we've got our group here, and Luke from our group will be addressing the
Fantastic,
discussion.
thanks.
So I'll share my screen, Luke, so you can see our discussion notes.
Thank you.
Wow, look at all these notes for you, Zaal. It's
It'll
great.
be a tough act to follow. We had a very diverse group with a diverse range of answers. We had infection control nurse, aged care, as well as 2 pharmacists. So we had a range of different things that we would be asking for and needing, such as executive support as a way of how do we escalate challenges with non-concordance with AMS pathways, when I guess there is pushback to recommendations on guidelines and ID. How do we better communicate with our local GPs, especially in like an aged care home situation, and increasing that coverage of AMS service into like some facilities, it's only in certain aspects of the hospital, doesn't actually extend to the entire healthcare service. So yeah, a really wide range of things to ask for and improve across our group, and in the unique challenges that we all had.
That's great. And I see there you've got some different evidence popping up. You've got, I'm loving what other services are linked to your health service in terms of aged care or community sites that have even a different type of problem, and how you can leverage those stories and that data for the need for a regional approach. Some really interesting stuff there. Do you want to, Luke, just recap now who you're trying to influence down the bottom?
Yeah, so again, that was a range. I guess prescribers were one cohort, executive were another. I guess, yeah, prescribers are obviously obviously such an important part of AMS, but we need executive support to be able to fund and change culture to be able to do so.
I think you've really hit the nail on the head there, but it's kind of identifying who in the executive has, I'm not going to say the loudest voice, but the most influential voice when it comes to advocating. I mean, there's a concept around sponsorship that some of you may know if you've done any leadership training around who's really going to be your champion, your sponsor when you take this. And it may not be who you report to. It may actually be someone different from safety and quality, or someone from anesthetics, or some, from a different angle, but who really gets AMS. So something to think about, Zaal. It might not just be who you report to. It might be another leader there who can take up your case as well. So it's not just seen to be your service asking for more money again. Something to think about. But thank you so much, Luke. I think that was great. Round of applause for Luke's team.
Thank you.
I'm going to flick back to the room here for any other thoughts, ideas? We've had some good ones already. Anyone else want to value add? Don't have to go through all the 3 questions, just anything you think might be useful that you thought of that was slightly different. Did anyone leverage the digital health stuff, or no? We've got some comments, thoughts here.
One of the advocacy elements, sorry, the first question, that I don't think has been addressed is we did jump to solutions a little bit over here, but we did talk a lot about thinking about ways to start to address those skill shortages. So look at how we can build more nurse empowerment or credentialing for some of these things into the hospital nursing, into the nursing education programs and that type of thing. And then we were also talking a lot about the difficulty getting pharmacists and trying to increase pathways, because there are a lot of pharmacists out there, trying to increase pathways from community-based pharmacists into hospital, and then ways that those people could be upskilled. So that was, I think really
it's great to actually include in your ask some non-traditional approaches. We'd love these couple of things, but we'd also love support for linking, for nurse educators to have some time to come and spend with us, to, just some other things that still require approval, because time is money in a health service. And so you still need executive buy-in for that, but it's just, they're not your big ticket items. So you can always, with an advocacy ask, have really what we're wanting is support for a expansion or to move to a regional AMS team with these components.
Absolutely.
Yeah. So I'm loving that capacity building and the alternate pathways, and particularly what we've seen, Sarah, what you were saying about what you've managed to do to support the nursing kind of stuff in Queensland gives you a lot of ideas of what you could potentially do. But it does still require someone to organise that. So it would still be part of your ask around, hey, we need a 0.2 educator or something. Yeah.
We heard a couple of days ago the Australian Digital Health Agency contemplating sending discharge scripts straight to community pharmacy without oversight from hospital pharmacists. So all the stewardship, I'm sure, would be fairly sort of terrified about that concept. So, it may well be that we're going to be in a position we have to start to think about how we're going to engage our community pharmacists if that actually goes through.
So links to community pharmacy could be perhaps even more important.
Also, because we've got our pharmacy prescribers out in the community, we haven't even talked about that here.
No, we don't know how that works, where Zaal works.
Yeah.
Let alone how our community prescribers in terms of primary care link in as well with the GPs. I'm thinking particularly aged care, that's important too. Yeah.
That sending of the scripts straight to community pharmacy may already be happening out in your smaller sites anyway. So that is how it is now, and it's already problematic.
Yeah. Yeah. So really, I think what this is telling you is that probably really important, Zaal, to have a very good grasp on your current state of play and where your kind of leverage points are, but then prioritise, right? Because it sounds like there's lots and lots of problems, but also lots and lots of solutions. And what do you want to do first? Could be another way to go. Any other thoughts online? Yeah. Well, let's hear from another online group. They're going,
Jenna.
Yeah, Cass, let's, do you want to chat?
Hello, hi. Look,
Cass.
hello. I just had one point that a couple of the people in our group talked about, which is just in relation to the stories, is in addition to kind of maybe patient experience stories, demonstrating and being very, very explicit where you're going to be falling short of accreditation standards or falling short of clinical care standards if you don't get what you want.
Yeah, no, very, very good point. Because who's responsible when accreditation is not met at the end? It goes right to the top, right? So that's, I think, a really important lever, and particularly then finding out in your facility who's in charge of standard 3. And quite often in a regional site, in my experience, I'm not sure if that's always the case, but infection control is often who's landed with this. Yeah. We've got a mic for Cassie. Yeah.
So not all countries have put AMS into infection prevention. So Canada explicitly put it into quality use of medicines. And those who've heard me talk, I also talk about the concept of AMS causing moral injury in our prescribers, because everyone is trying to do the right thing by their patient. They're not trying to harm them. And so AMS needs to move away from being seen as a policing through to, a toolkit to support optimal care. And
Which is the story.
And I actually truly think we need to reframe AMS away from an AMR issue to patient safety.
Yeah,
now, when I talk
agree.
about that, my executives really resonate with that. They accept that. So one way to do those stories is to get something that's been a significant event, critical event, essential event, where something happened relating to sepsis. Usually sepsis is good. And then do it before and after. So this is what happened to this patient, but if we had this in place, this is what you would see.
We would have been able to prevent this,
So
et cetera, et cetera.
Very good for the executives to see a before and after scenario, but also to think about which committees you go to. So I would definitely suggest that you ask to, if you're really having problems, ask to present to the board. So ask if you can go and present to the board, because typically the board will always have presentations from various either clinical groups or quality and safety groups as standard items.
They absolutely do.
And so if you can get your agenda, if you're really having trouble, I'd push yourself right up to the board level. And there's nothing like the directors hearing about, clinical issues and potential solutions.
And depending on what state you're in, there are other statewide structures as well. In Queensland, we've got a statewide clinical network in this space. But in addition, there's a clinical senate where all the chief executives sit, that's if you're wanting bigger than your health service. If you want to work with the health service next door and really get some big traction happening in the state, that's always good to kind of go to as well. Some good ideas there. Are we happy to kind of sum up now, we think? Yep.
It's fine because we won't start the panel now, but we need to do our summary and
Yeah. That's okay. I think anyone who typed up those beautiful sheets online and any notes here in the room, we're going to collate all that up, send that all around so you can see the breadth of ideas. So that's going to be really helpful for you.
Yeah, absolutely. There's certainly a lot to think of, and thank you all for contributing. Appreciate it.
Yeah, well, thank you, Zaal, for being so open.
No worries.
Great. So just to sum up now, let's just go next. Okay, so some take-home messages from me. You need to have a longer term view of your AMS strategy. Yes, we talked 5 years, but then if you get there, what would the next 5 years, the next 5 years? So kind of like your big vision and then work backwards from that. And so when you say what you look at things look like in 5 years, you also need to articulate that like that in terms of value for the health service, right? Is that reduced costs? Is that a sustainable workforce? Is it, better recognition of a strong patient safety record? Is it meeting all your accreditation targets? So what that longer term view is and thinking about your ask in that time frame. You need to really think carefully about your ask. And we had lots of good ideas. What you would then do, Zaal, is actually then prioritise within that. So you've got a really clear cut. If you're thinking, I don't know, what most health services have kind of a standard template for business cases, and you normally have a box with 3 bullet points up the top, size 12, 14 font if it's a ministerial, because ministers don't like to wear glasses. Anyway, that's just those of us who've worked statewide, but yeah, so you only get a small space to put your ask in, and then all the supporting material goes behind it. So you really need to refine that ask quite carefully. You need to build over time your evidence base, and you've had some great ideas there, particularly like the table at the back with other types of data that you may be able to request from medical records and other places. And really think about who your decision makers are. And in addition to your decision makers, when you have a look at this toolkit, if you go and have a look at it, it also talks about who your coalition of supporters are and who your opposition are. Now, in the public health space, they're talking quite politically, right? They go to Canberra and try and advocate who's who in the zoo, etc. But even within a health service, as I said, you'll be able to identify real champions, and you'll also be able to identify, I don't know if anyone ever read the Sanjay Saint paper about implementation of change. It came out about 15 years ago, and he talked about organisational constipators, right? Just leave that thought with you. These are the people that just will block everything, say no to everything, and you just have to work your way around them eventually. And then, yeah, use all of these tips to work your way further around that cycle to refine your advocacy strategy. And the most important word on that whole slide, Zaal, is tailor your advocacy strategy, because every advocacy strategy will be different and should be different, because no health service or model or advocacy ask will be the same. So much as we can provide business case templates, you really need to carefully look at what other stuff goes around that, so it's not just a templated ask. So that's the thoughts from me. Any final questions before we move on to the panel discussion to wrap up? Was that helpful? Okay, good. That's what we'd like to see.
Thank you so much, Lisa and Zaal. As a useful resource for everyone here, we heard lots of great contributions from the people who shared their ideas, but we didn't get to hear from everyone else. And so what we'll do at the end of this event is collate all of the feedback from the different groups, both online and in person, and then share those comments with everyone here today. And then you've all got some practical ideas to take away to your own settings. So hopefully that's useful. For our next session, we have our panel. So can I please ask our panel members, thank you, Zaal. Can I please ask our panel members to join us at the front? I'll let you do it. I'm going to let Lisa chair this one. You're doing a great job. Thank you so much. You do. For our last session today, we have our panel on sustaining AMS in regional Australia. And to recap what we've covered today, we've heard from the AMS teams, we've heard from clinicians, and we've seen a real-life case example as well. The next question has to be, how do we advocate for regional AMS outside of this room, outside of your hospitals, outside of the AMS teams? And what's the role of government or policy to help implement some of the ideas we've discussed, but also to sustain these ideas? And to do that, we have some excellent panel members with us today. We have Dr. Christian McGrath, who is a general and ID physician with extensive experience in multidisciplinary health environments. He has additional skills in education, journalism, and science. Christian was appointed as the Deputy CHO for COVID in 2022 and the Deputy CHO for Communicable Diseases in December 2023. Next to Christian, we've got Felicity in the middle. Felicity is a values-driven senior exec with over 25 years of experience in clinical governance, quality improvement, and public sector reform. Felicity is the director at Safer Care Victoria, where she leads statewide programs that improve health outcomes, reduce harm, and deliver system efficiencies. We all know Kaz. For those who don't know, Kaz is an international expert in health services research and digital health. She leads NCAS and RMH Guidance Group, and she's the inaugural director at the Centre for Health Services Research at Peter Mac. And we welcome back Dr. Tom from Royal Melbourne Hospital and Goulburn Valley Health. I'll pass it over to Lisa, who'll be chairing our panel session today.
Thank you all for taking time out of your busy schedule to join us this afternoon. Firstly, we really do appreciate it. And this is the part of the session where we want to kind of take it up a level to think more about those broader policy issues, broader strategic political directions. So we've really focused on what people can do locally at their health services, which is great, but obviously we're operating within a bit of within a context, right? And that context can really influence what happens locally. So there are some beautiful questions that Zohal has put here, and I'm not going to ask you all of them, or we'll be here all night. But I'm going to start with a question for you, Christian, around really around where you see AMS sitting from a public health perspective and how that fits in with your priorities as Deputy Cho.
Thank you. Is this on? Yeah, okay, sweet. Firstly, I want to apologise for being awkward and sitting in the room answering emails. Just a few things I had to get done for a Friday afternoon, but I was listening to some of the conversation. Yeah, I know. It was actually, it was interesting just hearing how some of the same issues you speak about at a local health service, are reflected on a state level, national level, international level. And I really liked the point you made, Kaz, about patient safety when you're advocating at a health service level, because different audiences, customising your advocacy is actually really relevant. And I've got to say, working in the AMR space more broadly, it's one of those really tricky areas because it's such a big problem. It's, multidisciplinary, it's everyone, and it's really hard when you've got governance structures which are very siloed. And we all know that. You work in a hospital, it's siloed. You work in a Department of Health, which is siloed. You work in a government, which is siloed. And it's really tricky when you're trying to engage that big picture. So I think the idea of tackling things at a local level, as well as at the big level, is absolutely critical in this sort of space. And I think when I think about AMR more broadly, in Victoria and Australia, where I can try and influence policy, I'm still applying some of those same advocacy principles that you sort of have already touched on. And I think it's just a different sort of, landscape for me. So I think when I think of antimicrobial stewardship, I'm actually kind of reassured because I know there's lots of strong leaders in that space working in the health service and advocate passionate people. And we need to ensure as a foundation that antimicrobials are used, fairly correctly. Sometimes it's going to feel challenging on a day-to-day basis. And I know this because I've done AMS before, when you're changing one order to try and improve patients' outcomes. And you're thinking, well, it might improve that patient's outcome. And this is why I think your point is really important. But am I making a huge difference to AMR when down the road there's 27 litres of ceftriaxone or something being put into food and that? So influencing those sort of policy levels are really important. But as I said, the patient safety and patient outcomes thing is a really important bit as well. I think for me, in terms of priorities, again, I think in our role in public health, we're never going to be able to influence, especially in Victoria, which has a more complex governance than some of the other states around how health services work. We're not going to be influence how prescribing takes place at an individual clinician level. I think obviously the standard 3, the Australian Safety and Health Quality Guidelines, those sticks, so to speak, for hospitals that get your executives interested is a really critical thing. But I'm also thinking about things like surveillance and capturing the degree of the problem, because the more evidence I can get to demonstrate a problem, the more I'm arming everyone in this room and everyone everywhere around how to, or the level of the issue, basically. So one of the things we've been moving towards recently is national notification of CPOs, for example, rather than just state-based regimes. And that'll likely progress over the next 12 to 24 months. Working with the ACDC, which is the new Australian Centre for Disease Control, which is being established on the 1st of January next year. We'll have a One Health unit and antimicrobial responsibility sitting within that. So there are bigger picture items on the horizon and things that we're trying to work through at that sort of high level, sort of policy level, to try and support those sort of functions. I think, though, when you get to quote outrageous figures like, what was the O'Neill pay? I think in 2016 it was $100 trillion cost by 2050 from AMR. I think people start to glaze over a little bit, but I mean, it's remarkable.
Citations for Jim O'Neill's track record at this stage, rather than actually having any impact. Kaz, do you want to value add to that?
One thing AMS is doing, and you're all welcome to participate actually, is that we are actually doing a national cohort study that my team over here are doing, where we're taking consumption data, NAPS data, antimicrobial data, microbiology data for key pathogens, E. coli, staph, as well as emitted episodes data regarding outcomes and triangulating all that data. And we're going far enough back to look to see the impact of standard 3 actually. So we've never really seen all that data done at scale at that level. We can do that now. We're starting to enroll sites. So, you know, we welcome collaboration more broadly for that opportunity, because I think that's evidence base that we need. All our data for surveillance for AMR are all in silos. There's NORS here, NAPS here, AGAR, Car Alert. We've already demonstrated if we can combine consumption data and appropriateness data. And in fact, what we've shown is in Australia very clearly is that we're very good at not prescribing restricted antimicrobials, and appropriateness rates are really high, 80% plus. Where we're falling down is all our under the radar, unrestricted prescribing, where 1 in 3 prescriptions is still inappropriate. Now, that is not even under the purview of many AMS teams. So therefore, we need to be looking beyond what the AMS team can actually manage to do as to how our broader prescribers, and this goes across the community as well, is doing with the, you know, amoxils and augmentins, cefalexins, etc.
Related to that, to Felicity, because I think one of the great things that Safer Care Victoria does is think really strategically about problems and then build capacity from the ground up to actually scale things. So do you want to talk a little bit about how you kind of address wicked problems like we're facing in AMS and your types of programs and implementation strategies?
Yeah, so for those that don't know, Safer Care Victoria is an administrative office of the Victorian Department of Health. And as Director of Improvement, I look at where there is variation or spikes in poor outcomes. But just on what you were saying, Kaz, it would be really interesting if you could, with that data point where like the sepsis 2018 program happened here, was there an improvement? The sepsis 2025 program.
We're hoping to do interviews alongside to actually map all the events. Yeah.
Yeah. Awesome.
This is national.
I digress. I apologise. And so look at where there's gaps in data, where there's variations in data, and we have a very strong directive from government to improve outcomes, but cost avoid. So how do we build an improvement program that supports improvement, because that is why we are all here. This is actually what we're here to do, to make a safer healthcare system for all Victorians, to make it more accessible and more equitable so that postcode doesn't matter, because it shouldn't matter for accessing care, to an earlier point from today. And we pilot, so where there is proven changes that have impact, we can scale that, and we have a safer medicines stream of work, safe use of medicine stream of work, which includes what some people have mentioned, that you're participating in some of those pieces of work, so such as delabeling of the penicillin allergy through the Check Again network. We have 20 hospitals who come and participate in that, mostly online community, but get together a couple of times a year. And so that is a proven package of work that we are able to scale. So we finance the support that does that. Health services can freely sign up to participate and access supports and resources, access quality improvement tools that are proven. So we have online packages that people can just access, online tools of quality improvement. How do you do quality improvement? Improvement is not research. It can be quick, but then also a community that helps support you as you're making those improvements. And you learn from others in that network as you move through your journey, which might be different to others, because there's no need to reinvent the wheel. We're also doing a sepsis collaborative. So sepsis is back to your business cases and your ask. thinking about your audience, what are the other levers that are happening in Victoria at the moment? For example, we all know that nationally there's a new sepsis standard, but then also Victorian public hospitals are now financially penalised for hospital-acquired complications. There will be a financial penalty applied for avoidable readmissions. How are you using that data? If that's the audience that you're telling it to, how are you using that data? How are you using a patient story to help inform some of that ask? And with sepsis, we have, when we pull together new work, we rely on experts like Kaz from Metro, from regional, rural, consumers, coming together in an expert working group to inform what should this change package, what should this improvement collaborative look like from a Victorian context.
Something really in the middle there. No, it's back on. I think it segues between them when you're speaking into one. It's too smart. You mentioned something really interesting there about how your programs support both big hospitals and small hospitals. So if people in Victoria, and we have some people here, interested in kind of tapping in or being supported by Safer Care Victoria, how do they go about that?
So we have a newsletter which you can easily sign up for, and it comes out every couple of months. And that will tell you what projects we have coming up. Our website lists the current projects that we have. So we have 4 under the medicine streams, which a number of people have said that you're participating in, which is wonderful. If you have any particular questions, though, really happy for you to reach out to me. The website also has the teams if you wanted to reach out directly to them.
I just wanted to come back to this issue because I was involved in the first sepsis scaling, and I remember we just sat down and we decided we'll put an EOI out and see what came back. Now the trouble is that those sites, some of the sites that didn't put an EOI in didn't know how to do an EOI. There's no one there to actually write an EOI, and in fact some of those sites are the ones that are the most needed to be involved. Hence that point I made during my introduction around using data and knowledge to drive where we need to invest. Is that fair comment?
That's a totally fair comment. Something that if you're looking to participate in a Safer Care piece of work, we have invested in the local health service networks and improvement. The program are on Safer Together program, a Safer Together program coordinator, and they have improvement teams, and they can help local teams in applying through EOIs, which it's a template that you follow, but you do need executive sponsorship to participate in any piece of work. So how are you telling that story? They can help you with that. So linking in with your local quality team, they would be able to link you in with the Safer Together coordinator for Victoria.
And I think that's a really important message. And there are like-minded people in a lot of states and territories who may not just be, they may not be the people that you would routinely go to, but they're the people that are, they may be leading safety and quality initiatives, but there are people that can help you frame your applications for these kind of schemes. So that's great. I'm going to, Tom, you're sitting rather pensive down the end there. One of the things that's really come to light in all of this is the really important role that partnerships can play. Who do you look to outside of your hospital to partner with when you want to do something interesting?
It's an interesting question. I've just been thinking about really the importance of government and how, Felicity and Christian, those regulations, be it standards, be it hand hygiene rates, be it immunisation rates, are a real driver, because sometimes ideas and advocacy are blocked because of organisational constipators or renegade clinicians, but mostly it's blocked by just lots of good ideas and not a lot of money. And the way that you get the good ideas to the top of that pile is by having the standards and so forth that says this has to come to the top of the pile. And I think that's where the standards and guidelines come in, that they really say this idea has to get to the top of the pile because it's necessary. Not just sounds good, we'll save $1 trillion somewhere for somebody that not paid. It's this idea is necessary this year for us to do.
Yeah.
That might not answer the question.
And I think that's great. And so I think that therefore partnering with those external groups and the Australian Commission, Safer Care Victoria, that can help you provide that. What is the policy landscape and why is it important for your hospital to consider now could be quite vital when you're looking to pull those kind of levers, right?
Exactly. Really knowing it and having that comparison and standard of what's going on in other places is really useful. The open question to all of our speakers here. How do you link in with professional associations, professional bodies? Or do we work around them? I don't know if we've got any GPs here today, but
we do link in with professional organisations. We have within Safer Care Victoria clinical chiefs. The clinical chiefs are the liaison to those professional bodies, and they can be real champions for us in some of our improvement work. We have to do business cases as well. We can't just do what we want to do. We have to lobby for funding to do the pieces that we do. And so having someone from AMA or whatever it might be advocating also is critical.
Bloody hard.
Yeah, that's what I was about to say. It's like I joked about working around, but it's challenging sometimes, right? Because they've all got their own kind of idea.
It's not just their own ideas, but own priorities, business models, etc., just like the health services. And I think that's why it's a matter of, using local levers, basically. So I think it's extraordinarily challenging. I'll be honest, from a public health perspective, where things are changing so rapidly all the time, to try and communicate to clinicians, whether it's a junior clinician in a hospital or a consultant in a hospital, someone who's quite engaged in public health, or 1,001 different islands that are GPs. It's really challenging. And I think it's about all the things I've spoken about today, whether it be, I want to say red tape, but regulation, standards, guidelines, because every time I make a new regulation, it's like, oh, I made more red tape today. But we do that because we're trying to improve outcomes. So, but even so, they're a double-edged sword as well. So it's really challenging trying to find the piece that matters to the audience, as was said, is the key here, the hook. And whether you use your champions, whether I use footballers to promote public health ideas.
Yeah.
What you find your champions, you find your hook for the audience you're trying to get to is just, that's that key part about the advocacy part you're talking about, and how you actually make it mean though to the group you're trying to engage in is always often really challenging. So I'm always looking for ideas on how to do that. So
do you work much with other states?
Yeah, I do at my level.
Yeah.
But again, every audience is slightly different. Every structure is slightly different. So how you communicate with clinicians in those settings is a little bit different. For example, I talk to my colleagues in ACT or the Northern Territory about how do you find out what's happening in the hospitals. I say, I just call blah, because there's just two of them, two hospitals or something.
It's very different.
It's extremely difficult.
Compared to how, Sarah, you would communicate to public health medical officers and throughout the state of Queensland. There's a few more of them than the one or two, right? And likewise in Victoria, yeah. Kaz, thoughts?
Well, I was actually going to make a comment. I think beyond hospital networks and government to your academic partners, because they're all dying. Every health services academic wants patients and data. You're the one that has it. So think about creating networks of research where you can, invite them out. This is where you can have access to, health economists and implementation scientists and all sorts of learning health experts to come out to your organisation, invite them to come and meet, offer to be part of whatever research they're doing. It's a very enriching experience because all of you naturally make very good clinician researchers, actually. And the second point to make is having a consumer in your antimicrobial stewardship committee, or if it's not its own committee, the quality is pretty much an expectation now, at least in Victoria, I know. That's very powerful to the exec. And I think that message that you have a consumer-led approach or patient-centred or patient-centred approach to stewardship again comes along with that patient safety message. So it's again how you present yourself externally. It looks great to have, academic links, consumer links, like something that's bigger than you and your own organisation, and that's also quite rewarding as well. It can be a start of something great.
As a university academic, I concur.
Exactly.
And one of the most lovely things that I've done over the last 15 to 20 years is actually collaborate with people. And I wasn't always an academic. I actually was a public health professional in the senior echelons of Queensland Health way back in the day. But since moving to academia, I really see the value of those partnerships, because I do think that particularly if you realize that everyone brings different skills, and you don't expect everyone working in academia to know everything about your health service, but likewise you could really leverage off the methodological expertise that the academics have. The trouble sometimes is academics work on slightly different incentives and timeframes, but there is normally enough people who like health services research who are a bit more agile, and it's a great way to get other students to help you work on projects and things too. So certainly we are always particularly in schools of public health, looking for placement opportunities, in Master of Public Health project opportunities where, this might be your point where someone can come in and look at your data, Zaal. Someone at the local university might be able to help you do some analysis that you could put into your business case, for example. I'm going to go off script now, and I'm going to actually ask if there are any questions from the floor, because you've got a wealth of expertise here. Were there any questions that you were dying to ask? And same for online. Pop anything into the chat.
100 people online.
Online. So surely. Not yet. Head. Yeah, or either that or pop it into the chat. Any questions?
I'll make a comment.
Yeah.
What you may not realise individually, you're doing the NAPS, and you can bench out yourself. There is absolutely no doubt that the NAPS results have been a major driver, actually, for reinforcing, both driving the updated accreditation framework and driving the future accreditation framework. It's been really important. And so we take that responsibility extremely seriously in our team. And so we are, you may or may not be aware of this, but it's been completely redesigned and rebuilt to be launched next February, be fully on the cloud with more guided assessments. So we think it's going to be more efficient. We again encourage you to work directly with us. So if there's a project that you'd like to do around NAPS, the data is accessible for researchers. So if one of you say, look, I'd quite like to look at, urinary tract infections in Queensland, we can provide data for all sorts of projects. So partner with us. We all sit together, the NCAS guidance team sit together. You can partner with us to do. You can even do national data sets, and you will have seen a number of amazing publications from our medical students looking at, the pattern of antimicrobial use. One very interesting one was when Augmentin first came in, and it was quite highly restricted. And you saw as soon as it came off restriction, IV Augmentin use shot up and PIP-TAS came down. So really quite a scissor effect. These are really interesting patterns that we can see. And the other thing you may not be aware of is we directly relate back to to therapeutic guidelines team. And one classic example was the overuse of azithromycin for hospital-acquired pneumonia. We fed back to them so they're able to amend their guideline to explicitly say, macrolides not required. So this is, you're all part of that. We can only do those sorts of things because of the power of the collective in actually doing the NAPS. It's a really amazing thing. And globally, it is really still completely unique.
Well, hot off the press, I was on a call early this morning with a US study I've been a part of. We've just surveyed infection control nurses throughout the country in the US, and 20% of them still don't have access to any antibiotic guidelines, and only half of them have any access to ID pharmacy support, and even fewer have access to ID physician support. So we're doing pretty well here. I have got a question if no one else. You've got a question, Court? Yeah, no, absolutely.
For everyone, but I'll put it towards probably Christian and Felicity first. We've heard today from Sarah the benefits of a Queensland statewide approach, and we've heard from Emily about the benefit of being part of a network. With Victoria, we don't have a statewide AMS program, and is that something as part of the long-term vision? Or I know that's putting you on the spot, but I mean, where do we go from here? I mean, there's no national program either. That's probably too much to ask for, but we've seen from other models that it it's working. So yeah.
I don't know if Iris can answer that question, if I'm completely honest. I mean, for those who are interstate, I mean, it may have already been covered today, but Victoria is unique in that it's got, what do we say, 76? Yeah, 76 different health services with health service boards, etc., which makes things 76 times harder from my perspective. But obviously there's community reasons for why that model's in place. It's a legacy, but certainly the establishment of the local health service networks, which to be able to talk about more, is an attempt to try and standardise some of the service support, I guess you could say, across healthcare delivery. I just wanted to pick up, before you answer that, can I just pick up one other point? The NAPS data is voluntary, which is fantastic. As I said, I use red tape to get my data. And it's worth noting that we do require the notification of a number of, not all resistant organisms, but we do require the notification of resistant organisms in Victoria, like CPOs, like VREs, etc. And we do publish that data online. And there are higher rates of CPO in regional Victoria than metropolitan Victoria. And, you know, we know there's experience with community MRSA probably originating in remote regions of Australia. So use those sort of numbers, use those facts to support your reason for why it's not just a Melbourne problem, it's a Victorian problem, for example. I expect that's probably true of other states as well, where reporting's mandated.
Yeah, we've got some questions coming from the floor. It's fantastic.
Hi, I'm Kate. I work for Ramsay Pharmacy Hospital in Shepparton, so I'm actually from the private sector. So I hope this is still relevant, but is there much, do you look at, I'm not sure who to direct this to, maybe Christian, do you look at data between the public and the private system and how it might sit? So for example, I'm, you know, a small regional hospital, we've got a huge GV Health up the road and Tom's there, but I don't have access to an ID physician as the pharmacist in charge, but we do our AMS round every week. But, you know, I do have my consultant who loves to use azithromycin and ceftriaxone for HAP, and I'm like, we don't want to do this. But you know, sometimes they say, well, that's what we're doing. And so as a hospital, we're trying to, you know, in the private sector, okay, how can we actually say, no, you can't? But do you look at the public versus private? You know, public, you've got your registrars and your interns who might well listen to the ETGs a bit more and say, no, we're not using that. And then the consultant comes across to the private and goes, this is what we're using. So do you look at that at all?
I wish we could say yes. The answer is no. So we have really limited data from private health services. Private health services don't have to report much centrally. So we have some data from some health services.
So I would think we've got a lot of data within Ramsay. So I wonder if, I can't speak on behalf of Ramsay Healthcare, pharmacy is a little separate, but, you know, there could be some collaboration there because it's a huge corporation and we do keep a lot of data on all of that. So,
I mean, from my perspective, we don't look at clinical data per se. So that's why we wouldn't look at a private versus a public health service. We're looking at public health sort of data, so demographic data, et cetera. And we also link it back using the central laboratory to genomics data to look for outbreaks. Also some epidemiological data in that space. And then from a public health perspective in Victoria, we then use that data to identify outbreaks. And then some of you will be familiar with the concept of TRA, which is transmission related areas, et cetera, which apply to health services to identify potential contacts in health services. So we don't distinguish in that respect from a public health perspective, though, in terms of rates of CPOs, et cetera, from a private or a public setting. But I think that data more likely exists in the hands of NAPS and clinicians, actually.
That's what I was about to say. It's actually, we have a large number of private facilities who regularly contribute to NAPS, and we do analyse public versus private, and we've actually seen a great improvement in the private side of things over the last 5 years when people have actually managed to pull together their AMS teams. But it's the same thing around an advocacy ask around why do you have renegade clinicians on contract, and what can you do around those contractual obligations to actually bring them into line? We managed to do that with hand hygiene to some extent, where people, if they really were poorly performing over many years, did not get their VMO contracts renewed. Sometimes I think regionally that's tougher because there may only be 1 or 2 plates, so they're always going to be, yeah. So you've got to think of other ways to kind of bring them along. As I said, make friends and influence executive and maybe influence some of those GPs and others who are providing services. We had there was another question over here.
Thank you. I'll be super quick. It's more just very specific for Christian. When you mentioned mandatory reporting of CPOs in every state, is that CPOs for Enterobacterialis only, or is it for different pathogens like Pseudomonas and Acinetobacter as well?
We're working through which organisms. We're working through what organisms would be included in that at the moment, actually. So most states and jurisdictions in Australia already have public health notification for multi-resistant organisms, but they're actually different in each state. And so not all states, but most. So this is to bring in what's called a nationally notifiable data set for each of those conditions so that we can get a national picture of the different organisms.
And that's great work that's being undertaken by the little small AMR team at the new CDC. They're the same people who help collate our aura data.
Yeah, exactly.
Yeah.
Just addressing your issue at the Ramsay. So if you ever have the opportunity to read one of Courtney Arano's PhD papers, which was a great bedtime reading, we did a theoretical domain framework, behavioural change framework around surgical prescribing in surgeons, anaesthetists and nurses. And there were some absolutely hilarious quotes in there that have amused me ever since, where one of the colorectal surgeons said, "Oh, I'd love to smear some feces all over a plastic surgeon's new flap and see how they react," because the colorectal surgeons know it's down to surgical, a lot of it's around down to surgical technique rather than the antimicrobials. The plastics are off the charts in terms of anxiety about losing their flaps. But anyway, the bottom line is, particularly for surgeons, probably this holds too for specialists in the private sector. They're their own, it's about them rather than the actual patient. But they will explicitly not care too much about guidelines. They don't care. They don't want other people to prescribe on their behalf. So they're very anti the concept of people taking over their prescribing decisions. What was a facilitator for behaviour change was good data and demonstrating their patients didn't do worse. We don't always have that. That's a problem. So what I would suggest for an area like that is you can use NAPS as a the new NAPS will have what's called focus NAPS. We call it a directed survey. So what you would do is you might have a network-wide audit of hospital-acquired pneumonia. You can capture the prescriber and look at that in detail and get, how many when you want. Then you call them together and discuss it together. So there's nothing more powerful than peers sitting in a room together and one of the other physicians say, "Oh no, I don't use azithromycin for hospital-acquired pneumonia," and they're in the same room, and that's a behaviour change that I've seen work in some craft groups. But obviously it comes down to the individual.
There's some handy hints there. This has been an absolutely fascinating.
And then let us go live, and then we can get in touch, and we can obviously help try to facilitate a Ramsay-wide board. There are things that we can help.
Yeah.
Try.
So for people online, Courtney was just explaining that once we go new with the brand new version of NAPS, which I almost cringe when I see those little dial reports now, Tom, that you put, it's like, oh, the new one is just gorgeous. We're hanging out to, and those of you who've seen a preview, get excited because we are. I think this has been an absolutely fascinating afternoon. I really want to thank everyone online who persevered with the technology, and hopefully you've learned something, those in the room, for being so open and constructive and thoughtful. Zaal, for putting yourself out there and letting us help you, and our amazing panelists, both earlier and now, for actually sharing their experiences and wisdom. And I think that I'm going to hand over to Kaz for a final wrap-up now.
Well, I concur with everything you said, and really actually to thank all of you for coming here today. It's just been amazing to have that engagement. Those of you that come into state, thank you especially. Felicity and Christian, to make that time in your busy diaries to come and talk to us. I think everyone's probably learned something today. I hope that you've all learned something. But what I would like to come out of this is a community of practice. We are the learning health community for rural and regional AMS. So following this, obviously we're going to collate all of the information that you develop through the networks, but we'd also like to encourage us to create that collaboration. And you will have met people today or seen people that you want to follow up with. Sarah, I suspect you're going to get quite a few calls. You know, I hope the takeaway today is that there's a lot of people struggling, but a lot of people doing great stuff, and let's share amongst each other. And thank you so much for your input. There are so many people, not just those people sitting up here, but there are all these workshop moderators also online who aren't in the room with us. So thank you so much. It's a lot of people to thank. Many of our team haven't been too well the last couple of days. So thank you for even pushing on, even though you're not feeling 100%. And especially a thank you to Rachel, who's always helping us. She's our indispensable office manager and quality manager from Guidance, who's helped us both today and also last Friday. She looks exhausted, actually. Court especially. Zohal actually works from Queensland now, so thank you for coming down. Lisa as well, she's been away from home for 11 days. And Jenna, of course, who's been doing an amazing job. So thank you for pulling the program together. I hope everyone's enjoyed it and enjoy your weekend.